फटाफट ज्वाइन कर रहे हैं लोग. हाँ, वाओ.
Yeah, participants are gone beyond 500.
See how it's coming. Tuck, tuck.
Webinar is live stream now.
No, we are not. No, this is practice session.
Probably I got a mail. This thing webinar is live stream now.
No. Till the president comes, it can't be live stream.
No, not necessary, yeah, Bajal.
Then you'll start.
No, unless he comes, we can't start officially.
That's what, na? Then live. Ah, here he comes. Good morning, Dr. Awad.
Morning.
Dr. Awad, can you start?
Sir, just a minute.
Yes, take your
Let
time.
me check the introduction PPT. Yes, sir, we can start. Good morning, Shah, sir.
Good morning, everybody. Huh?
Good morning, Arun Shah, sir.
Yeah, good
Mute
morning,
hai,
everybody.
Dr. Arun Shah, you are on mute.
Okay. Sorry, I was on mute. Good
Yes,
morning.
yes. Yeah.
Good morning.
Good morning, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for today's webinar regarding Alzheimer disease. Alzheimer disease is a big concern of late because many people have started showing the signs and symptoms of Alzheimer disease. See, God has given us two qualities. One is to remember, one is to forget. We always remember what good we have done to others and what others have done bad to us. And we always forget what bad we have done to others and what others have done good to us. So I believe that we should balance this, reverse this. And in good faith, if you do everything, then I think we will definitely remain away from Alzheimer disease. And now I'm not an expert on Alzheimer disease. We have got a team of experts who will speak on Alzheimer disease. Last year also we had a session, rather from last year only, we started this Alzheimer Day program and it was a grand success. So definitely this time also today it will be a grand success under the leadership of Dr. Arun Shah. So I request our president to give his presidential address.
Yeah. Good morning, friends. It's always nice to be with Dr. Arun Shah. Last year we did 2 programs and they were really a grand success. And today also Sir has shown keen interest in doing this Alzheimer Day program. Thank you very much, sir. As everyone knows, and Sir has already, Dr. Lad has already told you that this is the most commonest form of dementia now, which we are seeing across the whole world. And that is the reason, people should be aware what is Alzheimer disease, their symptomatology, and what best we can do for these patients as far as management is concerned, whether it is a psychological therapy or therapy at home given by the relatives as well as the caretakers, and of course the medical part, the pharmacotherapy part of it. So this is a nice platform where we can share all these things. And thank you very much, Dr. Arun Shah, again for giving us this program this year in a consecutive second year. IMA Mumbai branch is always thankful to you. Friends, as far as our forthcoming programs are concerned, we have a physical CME coming on the next Sunday, and that is also on the World Heart Day again. We are the World Heart Day is actually on 29th of September, and we are celebrating in Mumbai branch on 25th of September. It's a physical CME, and so do log in for this CME. I mean, do join this CME, physical CME, and attend the physical CME in IMA Mumbai branch, Haji Ali Hall. Then we today we had in the morning a walkathon on organ transplant, and it was also a good initiative taken by IMA Mass State, that we celebrated organ donation almost a month from 13th of August, which was the organ donation day, till 18th of September, and we did two good programs throughout this month. And thank you very much all for joining in large numbers. And now I hand over the mic to Dr. Kajal Ahuja, who will conduct the whole session from here. Thank you very much.
Good morning, everyone. To introduce the first speaker for today's webinar, Dr. Arun B. Shah. Dr. Arun Shah is consultant neurologist and PG teacher and director of Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Shah graduated with MBBS from St. G.S. Medical College and KM Hospital, Mumbai. He was awarded several gold medals from the University of Bombay. He then went on to obtain his MD in internal medicine and DM neurology at the same institution. He completed a fellowship in cerebrovascular disease and stroke at the Oregon Health Sciences University, Portland, USA. Dr. Shah has served as honorary professor and head of Department of Neurology and currently holds the title of Emeritus Professor at the Department of Neurology at Topiwala National Medical College and Nair Hospital. He has been in clinical practice for 30 years with special interest in stroke, dementia, and neurocritical care. He was the first neurologist in Mumbai to use reperfusion therapy in acute stroke in 2002. He presented his data on thrombolytic therapy of acute stroke in India at the World Congress of Neurology held in Sydney, Australia. He is the member of various international, national professional societies. Dr. Shah directs acute stroke program at the Stroke Ready at Sir H.N. Reliance Foundation Hospital with stroke clinic for the young and offers holistic care to patients at multiple sclerosis clinic, including latest disease modifying therapy. Today, Dr. Arun B. Shah will be speaking on basics of dementia. Can we prevent it? Over to Dr. Shah. Dr. Shah?
Yeah, I'm just trying to share my drive. Can you see it now?
No.
No, sir. No, sir.
DigiShield?
One second. Can you help me? I'm on iPad.
DigiShield, who's there? Dr.
Depends.
What?
Depend.
Hello.
Yeah.
Deepen, please help Dr. Shah.
Previously, we had just shared that screen. Share the same way and select your PPT on that screen.
No, I am on my iPad. So
You
screen, no?
Yes, yes.
And should I just start broadcast? Yeah, microphone on. Is it coming now?
Yes. Now select your PPT. Your screen is shared, but open your presentation.
It's already open. So 1 second. Yeah, it's open now.
Yes,
Yes.
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 You can see it.
Yes.
Yeah, thank you. Thank you, Dr. IMA and the Dr. Anil Awadh, Dr. Lad, and for this nice introduction. I must thank Dr. And I think this year's theme of presentation, last year we presented basics of dementia, which of course I'm going to do again in a short while. But rather than talking on treatment, which of course we have very limited treatment over the years, I think last 1 year, I don't think we have made any significant progress in the prevention. But we thought that treatment, since we not have a progress in treatment, we must try to prevent this disease. And is it preventable? So we have some new information on this, and I thought we'll share about and focus on prevention, which is not a rocket science, and it must start in middle life. And that's what we're going to emphasize. All of my colleagues which are going to talk on this probably is going to emphasize the same facts again and again, that if since there is no probably successful management of patients with dementia as of today, let us concentrate on preventing it right from the middle life. And that's what we're going to focus on. So let me start with the first slide, which of course again reiterates the definition of dementia. What is dementia? Dementia is impairment in at least more than 2 cognitive domains, which includes either language disturbance, memory disturbance, executive functioning, agnosia, apraxia. So these are the cognitive domains. At least 2 of them must be impaired to call it a dementia. It must be declined from the previous level of function, meaning thereby that if a person has already got mental retardation, he cannot be called as dementia. And finally, it must interfere with his day-to-day functioning. If the day-to-day functioning is not impaired and there is some cognitive domain impairment, we call it an MCI. And finally, of course, one should investigate to say that there is no better explanation for this process. And there is a lot of confusion in people's mind. What is dementia and what is Alzheimer's? I think we're going to clarify that again, that dementia is a general term, does not tell us about the cause of the dementia. So now, as far as cognitive spectrum with the aging process is concerned, there are 3 categories when a patient comes to us. But patient complains of forgetfulness. Now, the first thing we have to decide, is it our aging process itself? As you all understand, after the age of 55, 60, 65, there is always slight slowing in your performance, cognitive functioning. You may require difficulty in retrieving certain things, and probably if your memory is stored well, but sometimes retrieval becomes difficult. So this is not a dementia. This is just normal aging process. Then if you have only one particular faculty gone, such as person who has memory impairment is there, but with this memory impairment also, which is objectively or probably assessed by a physician that memory is impaired, and still he is functioning normally, we don't call it dementia, we call it mild cognitive impairment. Of course, as you all know, people with mild cognitive impairment, at about 12% of them will turn into Alzheimer's. So sometimes MCI could be a precursor of dementia. And of course, when the definition which I mentioned, if you satisfy, then it is called dementia. I'm going to further emphasize and criteria for dementia. That is a decline from previous level of functioning, impaired function at work or usual activities, not explained by delirium or a psychiatric disorder. And the diagnosis depends on history from a patient and a reliable informant. And of course, the bedside neuropsychological testing, which we do, mental status examination, or a detailed neuropsychological testing in many patients if required. So at least we have more than 2 criteria as shown in here. There is impairment of ability or acquire, recall new information. poor judgment and impaired reasoning, visuospatial problems like problem in finding ways, problem in dressing, impaired language functions. That means you cannot find a proper word or you make a lot of errors in your spelling. And finally, change in personality and behavior. That is BPSD, that is behavior and psychiatric issue associated with dementia. So if you have any of more than 2 of these, then you classify the person as having dementia. So, but remember, dementia, as I just mentioned, is an umbrella term, and it includes Alzheimer's disease, which is the commonest, probably accounting for more than 50 to 75% of patients. Then you have vascular dementia or vascular cognitive impairment, which really occurs in people with vascular risk factors, which is about 20 to 30%. Rare varieties of dementia, that is Lewy body dementia, where you have Parkinson's dementia, and of course the frontotemporal dementia, which is an early onset dementia, generally with positive family history. And now, of course, we also use mixed dementia, where you have Alzheimer's pathology and vascular factors together. And there is another variety of hippocampal sclerosis of aging, known as TDP-43, and this is increasingly diagnosed. So that these new entities which are added to the spectrum of dementia. So why are we bothered about dementia? As Dr. Lad already pointed out, that we are seeing increasingly more and more number of patients because our population is aging. And it is worldwide at the moment, it is almost 50 million people are affected, but this is going to increase day by day. Increases as the age increases, and 1 in 3 seniors dies with dementia. Alzheimer's disease causes 60%, as I mentioned, and the prevalence can be very well seen. This is also going to impact, does it going to impact India? In India, as of 2015, we have about 9% of population above the age of 60. When we reach 2050, that means almost 20% of population will be above 60, which means there will be almost 225% increase in the people with dementia. And this, while the population will increase only by 30%, the people with dementia will increase almost by 225%. So this is exponential as which is going to be, and it's well reflected in this particular chart, which is shown very well that in 2020s, you have about 5 million people with dementia. When you reach 2050, it would be almost 3 times. So it is really a public health problem. This is just a number game again. Estimated lifetime risk of dementia as per the age. If you are a man with the age of 65, about 9% will have dementia, while women it will be 17%. At the age of 75, 10% of men, while 19% of women, and at the age of 85, 12% of men, while almost 20% of women would have dementia. However, when you see a patient with dementia, first thing one has to do is rule out reversible dementia. And we are going to focus on that in a separate talk itself. My colleague, Dr. Ishu Goyal, is going to touch upon this, but I just mentioned this to complete the list that you have several diseases such as normal pressure hydrocephalus, neoplasm, subdural hematoma, alcohol, infective illnesses of the brain can present with dementia, and these are reversible. B12 deficiencies, thiamine deficiencies. So let's look for metabolic and treatable causes of dementia when you see a person with memory complaint. Now, coming to Alzheimer's disease and the dementia itself, there are certain modifiable risk factors and non-modifiable risk factors like any other cardiovascular diseases. So age is, of course, not a modifiable risk factors, which I already mentioned. Female gender is a more in frequency as compared to male. Family history and genetic factors, particularly ApoE4 genotype, which we'll mention. Lifestyle stress, person who has Brown syndrome is more likely to have Alzheimer's. Repeat head traumas are also one of the factors which can increase your risk of Alzheimer's dementia, and obviously traditional vascular risk factors, high cholesterol, hypertension, diabetes, and smoking. So these are, of course, the modifiable risk factors, which you all know, but obesity, physical inactivity, mental inactivity, depression, smoking, low education, of course, diet, which of course we need not worry because our diets are better, and these are early signs, memory loss, difficulty performing familiar tasks, disorientation to time and place, poor or decreased judgment, changes in mood, personality, and behavior, problem with language and spatial awareness, misplacing things, withdrawal from work or social activities, problems with language, and difficulty in planning or solving a problem. So if you find any of these are early signs of dementia. We should remember 7 A's, we'll skip this. And so when you see a patient with dementia, what we do as bedside in a memory clinic is the pre-diagnosis of dementia. That means we see the person's personal history, family history, and what is going on. Then we do a cognitive assessment. we do a functional assessment, behavioral assessment, and then decide what kind of personal care this gentleman is going to require. And this is done by a pre-diagnostic assessment, will consist of risk factor assessment, medical history, routine blood reports, which you are all very well aware of, and of course see if there are any early warning signs like gait disorder, frailty, or depression. And cognitive assessment, we use the informant-based cognitive assessment, and of course the bedside, mini-cog, MOCA, and of course the mini mental state examination. So these are the scores which are used bedside. And if required from this care, if we are not very clear, then we take help of our neuropsychologist, Dr. Karishma, to do a more detailed neuropsychology testing. And sometimes we do it as baseline and then do it again as a follow-up. Then, of course, the functional assessment. This, of course, you have to do with the family and decide whether the person is able to use a phone, can he go for shopping, is able to do certain simple cooking, whether housekeeping is possible or not, about laundry, transportation, medication. So functional assessment is required for every individual with dementia so that you can decide. Of course, we have a joint family system, and that's why these things are easily taken care of. But if you do not have a nuclear family, then of course, when you have to worry about these aspects very well. And behavioral assessment, which is, I think, many of these patients with present with behavioral disorder, including an NPI, that is neuropsychiatric battery inventory, is one of the assessment which you do in the neuropsychological testing to decide the needs for any psychoactive drugs or a behavioral therapy in patients with dementia. So this completes the clinical assessment. And then we decide which type of dementia is it. Alzheimer's, as we just already mentioned, the dementia I've already listed. This is the same list. And reversible causes should be ruled out again. And then, of course, every patient of dementia must undergo imaging once at least, and which would be either CT or MRI. And sometimes you can take characteristic findings you will see and at least rule out any treatable condition if required. So that this must be done in every patient of dementia. And this is just the list of MRI, which is showing you various things, such as you have temporal lobe atrophy, cortical atrophy, you have a dilated ventricular system, and these are the common MRI findings we see. We have the lower down images on the left side shows vascular changes in a small vessel disease, person who have a mixed dementia or a vascular dementia. The center is an SWI image, which shows changes which we see in amyloid angiopathy, amyloid deposition. There are black holes, which are chronic microbleeds, and there are, of course, the superficial siderosis, that is subarachnoid hemorrhage seen on the SWI images. And these are hallmark of amyloid deposition and is seen in many elderly patients with Alzheimer's disease. And lastly, you see patients who have hypertension and small vessel disease, which produces flared changes in white matter, again suggestive of a vascular dementia or mixed dementia. So characteristic feature for Alzheimer's dementia is usually gradual onset over months to years, clear worsening of cognitive abilities, and most of them, majority of them will present with memory impairment at the first measure, that is amnestic variety, learning, recall, most common presentations. About 20% may present with language dysfunction. They have a problem of and executive dysfunctions. It probably lifespan of Alzheimer's is almost going to about 10 years or so. By the time you make diagnosis, is already 3 to 4 years are over. And MRI might show temporal lobe atrophy as shown here. And pathology in Alzheimer's disease are 3 consistent findings, that is amyloid-rich senile plaques, neurofibrillary tangles, and neuronal degeneration. These changes eventually lead to clinical symptoms, but they may start very early. And that's why we have now biomarkers for this, which is amyloid can be diagnosed even before a person gets into clinical dementia, so or develops dementia. And you can tag amyloid or tag tau and demonstrate this. This is done either in the imaging nuclear medicine, or it could do with the CSF examination as well. And of course, FDG PET also can demonstrate a neuronal injury. So this is an example of fluor beta pair, which tags amyloid. And if you see the left side image on the A image, which shows there is no differentiation of gray and white matter. That means there is amyloid deposition in gray matter as well as white matter, and that is suggestive of Alzheimer's dementia. While the right-hand side image shows a normal pattern where you can demonstrate the white matter is differently and gray matter differently. So there's a normal imaging. And there are other isotopes which can probably tag amyloid, that is called 11C-PIP, and also tau can be tambled by 11F fluoro5-TP. Now, this is a serial imaging which shows as the dementia progresses. Able to see here is the first left side image shows that everything is green. There is no amyloid deposition whatsoever. It's a normal image. And if you see in the lower down image, there is some tau deposition, but it's restricted to medial temporal lobes. Now, the second side upper image, the PIB scan shows increased amyloid imaging, but this person is cognitively normal. It's important so that the amyloid imaging may start much earlier on the scan before the clinical syndrome is shown. In the tau also, there is minor abnormalities. As the person goes into MCI, you will see same amyloid deposition that does not change much. But if you see the tau, it increases. And then the last, when you get to dementia again, the tau deposition is much more extensive. So what we have learned now that 11-FFTP, that is tau deposition, correlates more with clinical dementia, while amyloid deposition can be used as an early diagnosis of a person who is likely to have Alzheimer's, and this kind of imaging might help in deciding treatment before the dementia establishes. There are several trials on this, but I think at the moment we have no success. So both the imaging techniques are still not available in India because clinically we don't find it useful because we don't have drugs to prevent the dementia from worsening at the moment. So also one should look at the non-modifiable risk. Out of all, most important risk factor is apolipoprotein E, the genotyping. So there are three genotyping, E2, E3, and E4. E2 is the commonest, and E4 is most associated with Alzheimer's dementia. So people are apolipoprotein E4 heterozygotes, your risk goes by random or ratio or odd ratio is almost 3 times the other population. And if you are homozygotes for E4, the risk goes to almost 8 to 12 times. While the E2 and E2, E3 are protective, and if you have that kind of APOE genotyping, then your chances of getting Alzheimer's are much, much less. And then, of course, there are monogenic varieties, which I don't think I'll go right now, but TRAMP, FPP, precelenin 1, precelenin 2, these are other monogenic rare disorders which account for only about 10 to 12, 15% of dementia, while APOE4 is the commonest population risk factor for Alzheimer's disease. Now, second, vascular dementia, I think the clinical signs are very clear-cut. They have early gait disturbance, frequent falls, urinary symptoms, pseudobulbar palsy, personality and mood changes. They have subcortical deficits such as psychomotor retardation and abnormal executive function. Generally, if you see that imaging, it will clearly show what I showed you in the previous MRIs. And this is generally vascular dementia. This is, of course, preventable if you take care of vascular risk factors properly. The Lewy body dementia is a long history arising from, say, 5 to 15 years. Initially, you will have pre-dementia stage where we have various symptoms, anosmia, RAM sleep behavior disorder, autonomic disturbances, increased salivation, increased sweating. At this stage, generally, Lewy body dementia is not diagnosed. The clinical features become of much later on, where they have episodes of delirium provoked by unexplained fever, psychosis, and direct episode Lewy body dementia is Parkinsonian features, extreme sensitivity to neuroleptics, fluctuations in their dementia, and visual hallucinations. So if you have these 4 characteristics that we always teach them, that this is a characteristic to diagnose Lewy body dementia, which is rare. Frontotemporal dementia is more often genetic. It's early onset. So if you have early onset dementia with certain features such as disseminated behavior, apathesia, loss of sympathy or empathy, pervasive behavior, compulsive behavior, hyperorality, and deficit in executive tasks. Now, generally, the memory is well preserved. Frontotemporal dementia more often present with behavioral issues and the disinhibited behavior. And then later on, they have loss of executive functions, but their memory is well preserved. Generally, positive family history is found in many people. And this is, of course, accounts for about 5 to 10% of dementias. So just a summary here, the differential diagnosis consideration in common dementias. So first is not reversible. If it is person is functioning normally, we label as mild cognitive impairment, acute onset, stepwise deterioration, risk factors, then vascular dementia, gradual onset, memory loss, normal examination, Alzheimer's. If you have Parkinson's, hallucinations, fluctuations, frontal deficit, visuospatial deficit, this is Lewy body dementia, and of course the behavioral variant of frontotemporal is mentioned. It might not be Alzheimer's if there's young age, develops quickly, and that is associated movement disorder. So can we prevent Alzheimer's dementia? So my next focus of next few minutes talk is going to be on prevention. Can we do something to prevent? declining age-specific risk of dementia and modified risk factors for. So where did the hope came from? The hope came from this studies from various that several studies have shown that age-specific incidence of dementia has declined over the past decade by about 13% per decade since 1990. The underlying causes, how why it has occurred is not understood, but many people say that management of cardiovascular disease and educational attainment are assumed to play a key role in dementia. So if you see the study, the 2013, Larson et al. In New England Journal published this. Although demographic will drive an increase in the number of dementia cases, recent reports generally based on population-based community studies or survey data point to a declining age-specific prevalence or incidence rates among people born later than first half of 20th century. So you will not see those decline number because of your population is aging. But age-wise, there is decline going on right from later part of 1930s and 1940s. And this is demonstrated in part of this is done in US population studies, UK, Netherlands, Sweden, Denmark. And the factors which are probably attributed to rising level of education, aggressive treatment of key cardiovascular risk factors, hypertension, and of course, dyslipidemia. So these are the main leading improving brain health and declining age-specific Alzheimer's disease dementia. So if you start early and take care of all these, dementia can be reduced. And that is now, is it evidence-based? Yes, it is evidence-based. We'll show it. Not only the developed countries, the country like Korea, they in a particular county they studied, and if you see the county is represented in the gray here, is the country they did it 12 years earlier, and then the next 12 years. And the next 12 years, they found that the AD dementia and all-cause dementia but decreased by 40%. And mainly they attributed that again to the educational level of older adults and declining time trends of this and lead to, so almost universally, many studies, population studies have shown that age-specific incidence is decreasing as the education level is increasing, and of course the risk factor control has also probably helped us. So 9 risk factors may explain 2/3 of cardiovascular. So middle life obesity, any evidence of atherosclerosis, low educational achievement, hyperhomocystinemia, depression, hypertension, frailty. So I think Dr. Ashutosh Shah is here going to talk about address this issue of depression and the risk of Alzheimer's disease, and probably that he'll probably help enlighten us on that subject. So is it primary prevention possible at a population level? Yes, you can do by risk reduction and promotion of cognitive health, which of course is again being covered in the subsequent talks, so we'll can't waste that. Important thing is as you know, the head trauma has become a huge issue. And we are talking about, because of a big accident, people are always talking about is now how to reduce brain injury and accidental accidents, and probably that would probably help reducing Alzheimer's dementia as well. Use of seat belt, use of helmets, fall prevention. So because head trauma itself is definite risk factor for probability, and this is a modifiable or preventable risk factor. Heart health, so quit swimming, diet, physical activity. Now, so if you, this is studies in, I think, late 90s and early 2000, early start of 2000, the CIST European trial, which was done for systolic hypertension in elderly, where they had used nitropin, enalapril, and hydrochlorothiazide if needed, and then control of blood pressure. And then probably they were looking at vascular risk factors, but as one of the subset, they also looked at the dementia and cognitive impairment. And their study showed that about 2,400 patients were followed up, average at 70, and 4-year follow-up. Long-term treatment of hypertension reduced risk of dementia from 7.4 to 3.3 cases per 1,000 patient years. So almost 50% reduction in the dementia with good control of systolic hypertension. So decrease in vascular and Alzheimer's dementia, both the types reduced, and this is what is shown in that bar diagram, which shows that those who were on placebo and those who were on active treatment, there was definite reduced incidence of Alzheimer's disease, as well as vascular and mixed dementia and overall dementia. So there is a new study about the exercise. I think Dr. Ashish Contractor will highlight on this, but I'm just addressing that this is a UK biobank study which looked at the number of steps you take every day and whether that helps in reducing the dementia. I think I'll just skip here. The conclusion was clear-cut that the dose of just under 10,000 steps per day may be optimally associated with lower risk of dementia. So now you can prescribe to a person that if you start in middle life about 9,800 steps every day, either in a routine way or specifically goal-directed way. It is going to reduce your risk of dementia. So exercise and brain health is a topic which I think Dr. Ashish Control is controlled. And these are the graphs from that, which shows that if you have 9,800 steps, that reduces the optimal. So you need not go higher than that. That is good enough to reduce your risk of dementia in future. Advanced management, high blood pressure, diabetes, which already talked, and midlife obesity, and that can prevent dementia. Activity, that is another important thing. Mental activity, learning new information and skill, volunteering, reading, playing challenging games, and social connections. All these things are also known to reduce DIM. So keep the brain active. And of course, these are the public health interventions. This, I think, as a family physician, all of you must be practicing this. And effortful mental activity and risk of dementia. This was a study which was done where people who played chess, checkers, and backgammon and cards game had a lesser incidence of dementia compared to who rarely played. Loneliness is another factor. So you should avoid social isolation, have purpose in life, which again showed study that approximately 2 to 4 times more likely to remain free of Alzheimer's. Of course, the edentulous state is associated with increased incidence of memory impairment. That probably correlation is not understood. Finally, hearing must be one of the important factors, which is studied in the John Hopkins study, that 32% faster for people with hearing loss than for those with normal hearing, and treating impairment in poor light. And finally, the diet, which I'll probably just skip right now and to save the time and complete my study by recommending the last slides will come. Conclusions are memory and thinking change with aging. This does not predict Alzheimer's disease or dementia. Tasks take longer, but can still be done. Many risk factors for AD can be modified. The glass is not half empty. Simple steps like exercise, diet, brain games, and focusing on wellness can protect the brain. This is not magic. Many of the exact mechanisms are, of course, not known. Healthy lifestyle choices may already be working in our favor. Thank you for your attention.
Thank you, Dr. Arun Shah, for updating us on the basics of dementia and also to how to diagnose the risk factors and control it. There's one question from the delegate. Sir, does tobacco consumption, staple food, regular consumption, and tea and coffee have anything to do with dementia?
Yes. I think that the last slide which I skipped it, what showed that they recently they have showed that if you have processed food, if you use more processed food, your chances of dementia are higher. If you convert yourself into unprocessed food, you're better. Tobacco, of course, also is linked to higher incidence of dementia in an indirect way. We don't know why, probably by increasing your vascular risk factors. Exact relationship is not understood. And of course, coffee is supposed to help. So coffee is not against it. It's probably help.
Okay, thank you very much.
Sir,
Any
one
question?
question. So nowadays, both hypertension and diabetes is on a high rise. So many people are taking these drugs. So any particular antihypertensive or any particular anti-diabetic has effect on dementia?
The anti-diabetic, I think right now we don't know any particular which will be helpful. But as far as antihypertensive is concerned, there are two important information there. Is we have the one study, progress study, and of course this CIS European trial. Now both of these probably address reduce the incidence of dementia, and all of them use ARBs, ACE inhibitors, and diuretics, and calcium channel blocker, and one of the drug. Now the other three trials, SHE, and there are two more other trials, SCOPE, they did not show a reduction in incidence of dementia. So maybe there is something to the class of antihypertensive use which is protective and others are not. Of course, this is still debatable, but this is the observation from what the two trials have been published. On that basis, we can say that. So ARBs and ACE inhibitors and calcium antagonists are definitely more protective than other drugs.
Thank you, sir.
Okay, thank you, sir. Thank you. Now, moving over to the next speaker, I'll request conveyor Dr. Sarita Devi to kindly introduce Dr. Ashish Contractor.
Good morning, all. Dr. Ashish Contractor is Director of Rehabilitation and Sports Medicine Department at Sir H.N. Reliance Foundation Hospital. Dr. Contractor completed his medical training at T.N. Medical College and postgraduate training at the University of Virginia, USA. He has been the head of Department of Preventive Cardiology and Rehabilitation Center at the Asian Heart Institute. He has the distinction of being part of the Asian Heart team, which created the Prime Minister of India, Dr. Manmohan Singh. His current research interests include mobile healthcare delivery, mHealth, in cardiovascular medicine, as well as the role of genetics in the prevention and treatment of the disease. He is the Vice Chairman of the International Council of Cardiovascular Prevention and Rehabilitation. He is a visiting lecturer at the University of Chester, United Kingdom, and serves the Certification Director of the American College of Sports Medicine in India. Dr. Contractor has been the medical director for the Standard Chartered Mumbai Marathon. He did a non-stop Mumbai-Pune-Mumbai cycle ride, 329 kilometers, with two friends, and in that process, he raised 1.1 crore rupees for children with cancer in April 2012. Today, he will speak on exercises for brain health. Welcome, Doctor.
Thank you. Thank you very much, Dr. Sarita. Thank you for inviting me. Thank you, Dr. Arun Shah, for organizing this. Thank you for IMA for always having these very interesting webinars and having them so well organized, and not just interesting. Every year I see that the organization is better and better. So thank you very much. I'm going to start sharing my screen and start with the talk. So let me share the screen. Are you able to see my title slide?
Yes.
Yes, sir.
Okay, so thank you. So thank you very much to Dr. Arun Shah for so nicely elucidating the components of Alzheimer's, how to diagnose it, and topics on prevention. I'm going to stick to one specific area, which is physical activity and exercise related to brain health. Dr. Arun Shah's one of his last slides said brush up, and that is nice because that's going to be my first slide. And I'm going to ask what might seem to be a very silly question to all of you, but please answer it in your own mind. My question is, how many of you did this activity this morning? And I assume with 750 doctors on this call, most of you will be saying yes and putting your hands up. So that's my first question. My second question is, in the last 24 hours, how many of you did this, or this, or something like this, or this, which means some form of structured physical activity or exercise, right? Just answer that question in your own mind, and we'll come back to this at the end of the talk. Today, we're going to talk a little bit about benefits of exercise as related to brain health. What should you do to get that benefit? I'm going to talk about what I believe, that movement is medicine, and a few take-home messages. Now, since we are talking about Alzheimer's, we're talking about dementia. Of course, these are conditions which happen later in life. So let's just look at this whole concept of quality of life as it applies not only to our patients, but frankly to us as well, right? What we call the geriatric curve. On your y-axis, you have your functional capacity, and on your right axis, you have age. So as we know that as you age, your functional capacity is certainly going to go down, 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 till one day you die. Okay, so very simple. And this last portion is what a lot of doctors are calling as deficient survival. What does that mean? It means you're living, but your quality of life is highly compromised. Now, this is the way all of us would like to go, right? Whatever life we have, whether it's 70, 80, 90, 100 years, ideally, we'd all like to be completely active till the very last day, one day fall asleep and not wake up in the morning, right? But very few people have the good fortune of having this kind of a curve where they're very active right till the end. And I've actually been hearing some podcasts over the last few weeks called the Huberman Labs, and I encourage all of you to listen to them. And Dr. Peter Attia, they're both neurobiologists at Stanford and in the US, where they are talking about how active you want to be in your terminal decade. What does that mean? All of us are going to have a terminal decade, which simply means the last 10 years of our life. For some people, it may be in their 60s, for some in their 70s, and some in their 90s. The question is, how active do you want to be in the last 10 years of your life? And it's important because what you do today in your 30s, 40s, 50s, 60s will decide how active you'll be in your last decade, because we know that physiologically with every decade, functional capacity does go down. So if you want to, for example, be able to play with your grandchildren when you're 85 years old, then at 75, you need to do certain things to be able to keep you active at 85, right? So your lifestyle choices that you do today will impact the future. As Aldous Huxley said, the goal is to die young, but as late as possible, right? We want to be healthy to the very end. And one huge aspect of being healthy is brain health. You don't want to be physically healthy and have lost your mental faculties, right? That could probably be one of the worst things. National Geographic some years back had a very interesting article where they looked at different populations around the world where maximum people lived over the age of 100. And there were three large areas. One was Sardinia in Italy, one was an area in California outside of Los Angeles, and one was in Japan, in island of Okinawa. And they all had different characteristics. But what were the common characteristics? And many of them Dr. Arun Shah mentioned in his last few slides. Don't smoke, put family first, having a good active social life, be active every day, keeping socially engaged, having a purpose, like he said, and eating healthy fruits, vegetables, and whole grains, and eating less of processed food. So all of these were secrets of living longer. I found a very nice review article on physical exercise in the prevention and treatment of Alzheimer's disease as I was preparing for this talk. And this line from the article caught my attention. It has been found that 6 months of exercise, so not even a lifetime, 60 minutes duration, 3 days a week, is sufficient to increase both the gray and white matter in the anterior cingulate cortex as measured by MRI in older cognitively healthy subjects. Now, the message out here is not exercise for 6 months and then stop, but the message being that even 6 months is enough to start seeing all of those great changes. And this diagram is from that article, which looks at the potential protective mechanisms of exercise on the aging brain. So you get increase in cerebral blood flow, decrease in oxidative stress, increase in neurogenesis. Neurogenesis and neuroplasticity is something which the world of neurology has been talking about for the past several years. How do we get new brain cells? At one time, we thought that we were blessed with a certain amount of brain cells in early adulthood, and then onwards it was all downhill. But today we know that that's not the case. And they have found three main aspects which help neurogenesis throughout life. One is exercise and being physically active. The second is having a healthy diet. And the third is lifelong learning. Learning never stops, whether it's doing puzzles, Sudoku, learning a new language, playing a musical instrument, that never stops. Exercise helps to increase neurotransmission, helps in neurotrophic factors. There's one called BDNF, brain-derived neurotrophic factor, which is supposed to be excellent for neurogenesis, and exercise has been shown to increase that. Psychological benefits, you feel better when you exercise, and it helps in hormone responses as well. There are two specific brain areas which are, help maximum with exercise. And it showed that those are the areas associated with memory and learning. And that's the hippocampus and the prefrontal cortex. This was the article which Dr. Shah was referring to, and he very kindly shared it with me a few days ago, and it's published literally 10 days ago, which was looking at association of daily step count and intensity with dementia, and 78,000 adults living in the UK. And they were followed for about 7 years. So very large cohort. And as Dr. Shah shared, what they found was that the higher number of steps was associated with lower risk of all-cause dementia. And they found that 10,000 was optimal. That was the main finding. But let me talk about two other sub-findings, which are very interesting. They found that as little as 3,800 or roughly 4,000 steps reduced the risk by 50%. I mean, 10,000 or 9,800 was ideal, but as little as 4,000 had a massive impact. And they also found that steps which were taken at a faster pace, typically they call it 112 steps per minute, which translates into a brisk walk, helped even more. And this message of exercise has come through in all studies of exercise, whether we look at cardiovascular disease, whether we look at some forms of cancer, whether we look at brain disease, that doing something is much better than doing nothing. And to get the benefits of exercise, people always tend to ask, what's the minimum? The minimum is very little. Okay, so you get a great benefit by doing very little. The second message is that doing your exercise at a slightly higher intensity, provided you're able to do it, definitely gives you more benefit than doing it at a lower intensity. So looking at brain studies, this was an article about 12 years back, very fascinating, when neurogenesis encounters aging and disease. And just look at this picture. A picture is 1,000 words, right? So these were in animal models, and essentially the top two panels were brain cells with advanced neuroimaging, and the bottom two are also brain cells. The top two panels were in animals who are not exercising, and the bottom two were in those exercising. And you can clearly see that in the lower panel, the amount of green, in other words, the brain cells, is a lot more. This is such a beautiful picture, which, a picture is 1,000 words. I'm going to stop talking for about 2 minutes now, and I want to share one quick YouTube video, which I thought was very fascinating. This is a TED talk by this lady called Dr. Wendy Suzuki, who's one of the leading researchers in the world in areas like Alzheimer's at the New York University. And I found her TED talk very fascinating. It's called The Brain-Changing Benefits of Exercise. And it's barely 15 minutes. I encourage all of you all to listen to it. And I'm going to share just 1.5 minute clipping from it, okay? So just bear with me while I start it. Are you able to hear it? Okay. So, that gave you a very nice summary of the effects of exercise on your brain and brain cells. So let's quickly, in the next 10 minutes, talk about how much should you do. Now, honestly, this is a subject which I've spoken about often, and I know I've addressed the IMA also on this, but let's quickly revise what we call the FIT principle, which is your frequency, intensity, time, and type of exercise. And what are the guidelines that the WHO and other organizations say? That adults should be routinely counseled in healthcare visits to optimize a physically active lifestyle. We know that. And you should engage in at least 150 minutes per week of accumulated moderate intensity activity. Okay, remember it says at least, not maximum. 150 minutes is as simple as 30 minutes, 5 days a week of moderate intensity. And we'll talk about what is moderate intensity. Or 75 minutes per week of vigorous intensity. So something like 25 minutes 3 times a week. We typically measure intensity in terms of METs. MET is a metabolic equivalent related to the amount of oxygen consumption. 1 MET is the amount of oxygen all of us are consuming at rest. And we can look at all activities in MET. So brisk walking, for example, walking 1 kilometer in about 10 to 11 to 12 minutes would be considered moderate activity. Anything more than that would be considered vigorous, right? So a brisk walk of 30 minutes, 5 days a week is good enough. Of course, that's not the maximum that you need to do. That's the minimum. Strength training. What about strength training? All the research over the last 50 years has been focused more on aerobic training, but now we have more and more research even on strength training. And strength training also has a lot of effects, both on cardiovascular health and brain health. Here you see a lady, she's balancing on 2 balls and lifting a heavy weight in her arms. This lady is 77 years old. So even with aging, it helps. And let me tell you one little secret. This lady in the picture is actually my mother. I asked her to take this picture. Okay. So at Sir H.N. Reliance Hospital, thanks to Dr. Arun Shah, we work with the patient in a team approach. At the center of everything we do is the patient and the patient's family. Then we've got the neurologist, we've got the rehab doctor, physical therapist, yoga and speech therapist, nutritionist, and for brain health, very, very important, is our neuropsychologist, Karishma, who's also going to be addressing you shortly. So we take a team approach for all of these patients to help them thrive and do better. Let me end with a couple of slides on what I call movement is medicine. What is this cartoon trying to tell you? What it's telling you is that sitting is the new smoking. We know that smoking is terrible for health. So now we know that just sitting for long periods, like in conferences like this, is also detrimental to health. So just keep moving. So most of you are listening to this conference at home. So you could easily be walking around in your living room while listening to this, right? The less time you sit, the better it is for your health. And research has shown this. It's not something that I am talking to you about. Things like sugar control, blood pressure control, even cholesterol, all of these things are helped with just more and more movement. That's why I call it movement is medicine. And I truly believe that, especially for all our neurological patients as well, the more you get them moving, the better their quality of life and all aspects of their life. You know, simple ways that people do it. I gave a talk once and I spoke about a standing desk. So this gentleman was in the audience. He's the head of BASF. And he sent me a picture. He's got a standing desk. So here he's sitting and talking, sitting and working. And then that same desk converts to a standing desk. Okay. So these are just simple things that people can do to just stand more, be more physically active. This is a picture of Dr. Shiv Prakash. Many of you may know him. He's one of the leading pediatric cardiac surgeons in the country. And he's at Sir H.N. Reliance. And we exchange notes often. And during the lockdown, when we couldn't get out, he used to actually run in his living room at home. And I made him send me this picture. And as you can see, he was taking, this was in May of 2020 at the height of the lockdown. He was doing 104,000 steps in a week, of course, not in a day. That's there's about 15,000 steps a day he was doing. So, you know, it's not a question of having time and everything. It's a question of how much you want to do it, right? This is a picture of Fauja Singh, whom I've had the privilege of meeting. He is a Indian Sikh gentleman living in the UK and Canada who ran a full marathon, 42 kilometers. Of course, ran at the age of 100. So really, there is no excuse of time. There's no excuse of age. We can be physically active at all ages. Here is a picture of another very, very active gentleman whom all of you will, of course, recognize and whose brain is very, very sharp and continues remaining active. So in our hospital, we have a small mini rehab area in our inpatient setting. It's on the 17th floor. And Dr. Arun Shah is a frequent visitor there. And I know that he also quickly sneaks in little bouts of physical activity through the day. So here is him practicing what he preaches. So, I want to really end with some very, very simple take-home messages. And I'm going to stop sharing now. And the take-home messages are very simple. We know that exercise has a profound effect on brain health. It's not just on brain health. I think it's on all health of the body, right? I don't think there is a single body system which is not affected very, very positively through exercise, and not just exercise, physical activity. A lot of the people that we will deal with, maybe including ourselves, what we call as the sort of, white collar or other office going white collar workers, where throughout the day you avoid activity and then you may, go for a half an hour walk. The idea is you've got to do both. Get physically active, take the steps more often. Again, to give Dr. Arun Shah's examples, we have wards from our 16th floor to the 19th floor, and I have frequently seen him up and down on the steps between those floors and not taking the elevator. Or in the old heritage building where his offices, the floors are double length and he's always walking up the floors. So those kind of things, taking the steps instead of the elevator, parking your car a little further away. All of these, in addition to that 30-40 minute walk, which you will take 5-6 days a week, goes a very long way in helping both brain health and all health. So thank you very much, IMA. Thank you, Dr. Arun Shah, for inviting me. It was a pleasure addressing you all this morning. And my apologies to the speakers who are going to follow me, because I'm going to actually have to exit soon and head out to the suburbs for another meeting. So thank you very much.
Thank you, Dr. Ashish Contractor, for the nice talk on exercises for the brain health, and also reminding us the importance of exercise. Your sentence, movement is medicine, I'll remember for life, and I'll start doing.
Thank you.
Okay. Now, any questions from the panelists? Okay. Thank you, Dr. Ashish.
I
Contractor.
have one question.
Okay.
Yeah, Sachin Patharkar.
Haji.
Sir, I am a marathon runner. I had completed 3 marathons, 42 Bombay Marathon, and a lot of 21 kilometers. So my question is that recently, after 2 years, I again registered for 42-kilometer marathon. Am I audible clear?
Yes.
Yes.
Yeah, I registered for 42-kilometer marathon recently, which is coming up into the January 23. So for that, after 2 years of gap, I thought I should go scientifically, and I had evaluated myself cardiology point of view. So at the time of examination, cardiologists don't advise such extreme level of exercises which are arrhythmogenic. So please enlighten us on this.
So, Dr. Sachin, this is something I think we can have a detailed talk of this offline. The other invitation I can tell you is I'm heading to the Lalit at Sahar right now for a cardiology conference, which I'm going to, this is the exact subject I'm talking about. Is there something like too much exercise? But since you asked this question, let me just give you a one-line answer. See, we know very well that for good health, one needs to exercise 30 to 60 minutes, 5-6 days a week, right? Anything you do more than that, like running marathons, I mean, I run marathons myself, so anything you do more than that is not necessarily just for good health, it's for a sense of achievement. So that's a question which we need to answer on a very individual basis. There is no hard and fast rule as to this is how much you can do. So I repeat, for good health, you don't need to run marathons. If you want to run marathons, that's for a sense of achievement. And that's a very individual pros and cons that we need to talk about. And I'm happy to sit with you anytime and we'll have a longer talk on this.
Yeah, thank you, sir.
Ashish, can I ask you a question?
Yes, sir.
No, I think this UK Biobank study also mentioned about 112. So I just wanted your opinion on that. Is it enough? High intensity 112 is supposed to be enough. Is that correct?
No, so what they found, and this is something that has been found in a range of studies right from the, I would say early 90s onwards for cardiovascular, for cancer, for brain health, everything. They know that moderate intensity exercise, like we're talking about, that brisk walk, correct? That brisk walk is very good as a public health message, which means as a society, all of us are very sedentary. And as doctors, when we talk about, the message to 1 billion people, the message to 1 billion people is get moving, get off from your sofa and start moving. So moderate intensity, great benefits. However, studies have shown that a vigorous intensity, which is, that cutoff is, say, walking faster than 10 minutes per kilometer, definitely has greater benefit for all health parameters than just moderate if you're able to do it. But as a public health message, that's a problem because people get put off. You tell people start running or start cycling fast, they get put off. Wo nahi kar sakte. But you tell them walking is not a problem. So what this UK study saw was that when people they defined, fast walking as more than 112 steps a minute. Again, that roughly will translate into that 10 to 11 minutes per kilometer. But they were not continuous steps. So they were like somebody walked for 5 minutes fast during the day and then 5 minutes in the evening. So they added it up. But the simple message is that a brisker walk or a faster intensity would be more beneficial. So to give an example, let me use you as an example for the audience, right? You're a very physically active person. You are seeing patients left, right, and center. Whole day long you're walking. So if one has to put a pedometer on you or a step counter on you, I am fairly certain that you will easily cross 6, 7, 8, 9,000 steps in a given day. But in addition to that, so that's going to give you great benefit. But in addition to that, if you got onto a cycle or on a treadmill, lifted weights, and you did that at least 2 to 3 times a week, that would optimize the benefits that you could get. And you also know very well, we've discussed that even for things like Parkinson's and all, even as a treatment today, we found that cycling has got a great benefit. So that once people have moved from zero to being active, then we should encourage them. Why not take the next step?
Ashish,
Yes, Dr.
Ashish, can I ask a question?
Yes, sir.
Yeah. So before you leave, would you also tell us the third prong of physical activity resistance training? And do you think all people in middle life, me, Dr. Arun Shah, and many people who are present here, should also invest a little bit in resistance training?
I would say 100%. And I think that's the most neglected area, because especially as you're aging, see, your muscle mass reaches its peak at about age 30. And after age 30, every decade it starts declining. And after 50, the decline is even more. So as I spoke earlier, this whole concept of terminal decade, right? We all need to know that when we are 80, do we want to be able to lift our grandchild from the floor? Do we want to travel and be able to lift our suitcase and go to the airport or have someone do it? See, now in India, you always have people doing your work, so one doesn't need to. Do you want to be able to do those things? Do you want to go grocery shopping and get a 10-kilo bag? So resistance training is very, very, very important, especially for women. Again, for osteoporosis as well. The one natural way of preventing or reducing or making your bones stronger is resistance training or weight-bearing activity like skipping. Skipping is a great exercise. Because again, as you age, we spoke about falls. Now, a fall is not bad in itself if there is no consequence of the fall, which means that if you fall and God forbid have a hip fracture, we know that after age 65, mortality, 1-year mortality is very high after a hip fracture. So if you fall and don't fracture your hip because your bones are strong, then that's not too bad. So resistance training is going to help that. And again, I say especially women, because their muscle mass is not a lot to start with and it declines a lot after menopause as well. And simple things, you don't have to go to a gym. You can lift a bottle of water as a 1 kilogram weight, 1 liter bottle, and do that. You can do something this. You can do things at home. You can stand against the wall and sort of do a half sit up. You can stand against the wall and push yourself. So, absolutely right. We could have an entire session on this, but no question. So twice a week, try and do 15 to 20 minutes twice a week for good benefits. Of course, you can do more, but that's a minimum.
Thank you.
Okay. Thank you. Thank you, Dr. Ashish Contractor.
Thank you. Thank you so much for having me, and thank you for the lovely questions.
Okay, now moving on to the next speaker, Dr. Ishu Goel. I'll request Assistant Secretary Dr. Kashyap Dakshini to kindly introduce the next speaker.
Morning, friends. Dr. Ishu Goel is working as an associate consultant at Artemis Hospital, Gurgaon. She's part of the DNB training program, Movement Disorder Clinic and Dementia Clinic. She did her MBBS from Sardar Patel Medical College, Bikaner, MD Pediatrics from SMS Medical College, Jaipur, and DNB Pediatrics from Shishu Sadan Hospital, New Delhi. She pursued DNB in neurology from Paras Hospital, Gurgaon. She worked as a senior resident at Omni RK Hospital, Visakhapatnam, and B.L. Kapoor Hospital, New Delhi. She worked as an associate consultant at Sri Action Balaji Medical Institute, New Delhi. Her area of interest in neurology includes movement disorder, dementia, and stroke. She has many national and international publications to her credit. Today, she will speak on how to recognize treatable dementia. Over to Dr. Ishu Goel.
I think we should correct her. She's associate consultant at such HN Reliance Foundation Hospital.
I was about to say that, sir.
I was so amused when I saw that.
Okay.
Good morning, everyone.
Apologies.
Thank you, IMA and Arun Shah, sir, for giving me this opportunity to speak on the topic, how to recognize reversible dementias. Just give me a moment to share my screen. I hope it is. Can everyone see it?
Yes, yes.
Yeah. So, Dr. Arun Shah, sir, has given us a fair account of the burden of dementias that is existing currently and in the coming few years.
Excuse me, Ishu, sorry to bother you. This is not a screen. It's still you have to show. It's on a slideshow mode at the moment. Please correct that.
is it on the like full screen is visible?
No,
Not your
no.
issue. Not your issue.
I think you're making the same point which we made in the last team meeting.
Yes, sir, but I joined like that only, keeping that in mind that that should not happen again.
Go to slideshow, madam.
So is it any different now?
No, it's the same.
Can anyone from the IT help me out here?
Deepen?
Yes, yes. You have clicked on the full screen.
I've done that already.
Yes.
I'll stop sharing and try to share once again.
Just share the screen and select the entire window. You must be having the option at the time of sharing the screen to select the windows.
That's what I've done. I have selected Windows only. Still the same?
Now we can't see anything.
No, we can't see the screen. Can you just select again?
Yeah.
Can you please share your screen?
Yeah, I'm trying. Can you see it now?
Yeah, we can
see your
see.
screen, but it's not a full screen.
Anyway, carry on.
Yeah,
She
some
can
people do
check.
this. Okay, we can see it. Dr. Ishu?
Put that slideshow.
Yes, sir.
No, put that slideshow. Do it that slideshow.
Sir, I've done. Yes, sir. Yes, sir.
No.
I did that.
Okay, ठीक है.
Yeah.
Carry on.
So we know about the burden of the disease and the number of cases that is going to enormously increase in the coming few years, and it is really scary. But what was more scary was that there is no actual and definitive treatment to this disorder. So the onus is up to us to recognize the few cases that are actually reversible, diagnose them in time, and at the same time not overdiagnose, and offer them a treatment when there is actually a chance for the reversal of the disease. So I would be discussing some of the causes which are commonly seen and sometimes missed also. And we hope by the end of the presentation, we are more wiser in diagnosing the reversible causes of dementia. So degenerative dementia, first we need to understand that what amount of percentage of dementias is actually contributed by the reversible dementias. So when we see, it is approximately like 20% of the total dementias are actually reversible. So when I talk about reversible dementias, there are two components to it. One is that one is what is actually reversible. It is not a neurodegenerative process. Some of the causes like nutritional deficiencies, infections, autoimmune causes are the isolated cause of reversible dementia. And apart from that, in an underlying neurodegenerative disorder, sometimes we see that in a stable neurodegenerative disorder, which is slowly progressing over the years, we see an acute deterioration in the previous status of the patient. And that may be because of some additional factor which may be correctable and reversible and improve the quality of life of a patient who has a neurodegenerative disorder. So recognition of both these things, and isolated reversible dementia and some of the contributory factors which are responsible for worsening of a neurodegenerative dementias, the recognition of both is important. So 20% of cases of the whole lot of dementias are reversible, and another 23% are the comorbidities that tend to worsen the
Sorry,
pre-existing
issue your
neurodegenerative
slides are
process.
not going up. Issue your slides are not going forward. Now
Sure.
it is okay.
Okay.
Yeah, carry on.
Yes, sir. So why do we need to recognize reversible dementias? Because there is a variability that exists in the presenting features and course of neurodegenerative dementias. As sir has already highlighted, there are various types of neurodegenerative dementias like the Alzheimer's disease, frontotemporal dementias, DLBs, vascular dementias, and all of them have different set of presentations and different progression of the disease. But overall, the response of the available therapies and outcome is often poor. So the recognition of a few percentage of these patients with reversible dementia hence becomes important, because here we have something to offer to the patient and improve their quality of life, as well as decrease the burden of the caretakers. The additional investigations in such cases should be decided solely on the clinical judgment. We do not have a huge panel that can be sent in all the cases of reversible dementias. We have to be clearly focused depending upon our clinical history and examination, that what kind of disorder we are expecting in this person and what set of batteries of investigations to be sent. And expedited access to treatment may reverse a decline. As I highlighted earlier, modifiable causes leading to acute exacerbation of pre-existing dementia should also be looked upon. So whenever we are investigating any of the reversible dementia, that should be kept in mind, that what are the main chances of it being a actual neurodegenerative disorder, so that we do not over investigate, do not give a financial burden to the family, and at the same time do not miss out on any of the reversibility of the disorder. So first of all, in our OPDs, in our clinical settings, we generally see people coming up with forgetfulness, but that forgetfulness is actually not always dementia. Sir has told that there are some percentage of cases who are who have mild cognitive impairment that is not impairing their quality of life, that is not hindering with their activities of daily living, but 15 to 20% of cases may progress to dementia. So above 60, we tend to have a minor misses in our memory, making a bad decision once in a while, missing a monthly payment, not being able to recall a name, but if you stress too much or after some time spontaneously that name comes to your mind, and sometimes forgetting which word to use, losing a few things from time to time, but overall you are functional. So whenever a high performing individual like doctors ourselves, so they are quite aware about their misses in the memory, and these high performing individuals are the first to come to the memory OPD to get evaluated. So once in a while getting these misses done need not always indicate that you are bound to get dementia. But if these misses increase drastically, if you start making poor judgments, bad decisions most of the times, forgetting bills, paying bills frequently, losing track of the date and time where initially you were able to remember the anniversaries, birthdays, all in a very systematic manner, and trouble having a conversation, forgetting the conversation altogether. These things indicate that a person truly might be having dementia, and it needs to be looked into that what kind of dementia it may be. Then finally it comes to us to find the needle in the haystack and see whether it is a neurodegenerative disorder or whether it is a reversible dementia. So there are some red flags in our history and examination which we should ask the patient and dwell into it. They might not be aware of the fact, but we need to ask all the questions in detail, and along with the family members also probing should be done, and see if we can find any particular risk factor in the history taking. So evaluating a cause of reversible dementia, it can be done in two forms. either we can just follow a checklist of all the causes, but then it involves using a lot of resources and a lot of investigations. But if we go systematically and do our clinical history first and then examination, then we would be able to narrow down our differential diagnosis and we can investigate accordingly. So these are the red flags that I'm talking about. These are solely on the basis of history taking. So rapid unexplained decline in the function, who was a previously high performing individual, even above 70. Many people come who are entrepreneurs and they are doing very well in their life even after retirement. But sudden unexplained decline in the function may be alarming to the family members. And that is the first sign that they might present with. After that, younger than expected age at the symptom onset. Approximately, like the people who come with memory decline are mostly above 65 years of age. But if a person is coming earlier in their early 40s or 50s, then it gives you a red flag, and you must investigate such kind of patients. Then prominent fluctuations in their day-to-day activities. Sometimes they are absolutely normal, and sometimes it feels that they are totally zoned out and they are not in their environment, and like they are totally not conversant at a particular time, but after some time they're as good as normal. And then these are the two things: acute and chronic high risk exposures, and acute and past and present high risk behaviors, that the historian may not come forth with on his own. And you have to actively ask and repetitively ask them if they're in past. And past, by past I mean like 15-20 years back also, they might come up with a history that once in a while, yeah, yes, they were exposed to some kind of high risk behaviors that may give us a clue regarding the etiology of the dementia. And then when we come to the examination, usually in neurodegenerative disorders, we do not find any particular kind of focal neurological deficit. But then if there are some unexplained findings in examination, like some focal neurological deficit, gait disorders, or differences in the tone upon motor neuron signs, so these all are mostly not seen in neurodegenerative disorders, and they should give you an indication that it is a reversible dementia. And then neurocognitive testing, incongruent with the clinical history, that I would be elaborating ahead. So first, just after we are done with our history taking, depending upon what kind of red flags we are getting, let me discuss the causes which can be most commonly associated with these kind of histories. So rapid unexplained decline has a huge checklist, and that I'll be coming to that checklist. But majority of the cases, the initial set of investigations that we generally order are the serum studies and an MRI examination. And depending upon our history, other red flags, MRI findings, we further plan if CSF, EEG, and all those things are required or not. And even after that, after getting CSF and EEG, if we do not have a clue, then we can plan further investigations like the PET scans and detailed serum studies in specific cases where our index of suspicion is high. Then the younger age of onset, we all know that autoimmune encephalitis is a very common cause, not a very frequently presenting one, but a very important cause to be recognized early and treated early before it becomes too bad and becomes difficult to treat. And they usually present at a younger age, but above 70s also autoimmune encephalitis do present, and age is no bar. And although they are more common at a younger age, but even if an elderly is presenting with a rapid cognitive decline or subacute cognitive decline, autoimmune encephalitis should be the first in the differential list because it is actually treatable. Then prominent fluctuations. The most common cause of fluctuations that we see in our clinical settings, particularly in the ICU settings, are the toxic and metabolic disorders. We frequently get a call that person who is undergoing dialysis or is a chronic liver disease patient has suddenly become dull and drowsy, and we get a neurological we get a review for him that why these fluctuations are there. But the most common causes are the toxic and metabolic disturbances. And in addition to that, because of polypharmacy and so many medications, sometimes a person becomes restless. We tend to give sedatives, and then the person is totally zoned out and totally dull and drowsy for the coming few days. So these two are the most common causes that we see in our clinical settings for fluctuations. Then untreated sleep disorders, psychiatric illnesses, and transient epileptic amnesia, in which a person may have a non-convulsive kind of epileptic discharges inside his brain. that is very transient in during that period of time, and after, for the coming few hours, the person may not respond to his surroundings. He may be looking alert. He may not lose consciousness and have frank tonic-clonic seizures, but he is having epileptic activity in his brain, which has disconnected him from his environment and led to the has total amnesia for the event, and these events may be repetitive. So they might present with very frequent fluctuations, that like for 3 to 4 hours in a day he does not understand what is going around. There's no memory for that episode, and over a period of time, when such episodes accumulate, then they lead to a progressive cognitive decline. So recognizing these small events is really important, because the diagnosis is very simple. You get a prolonged EEG done, you're bound to witness one or the more episodes, and it is easily treatable by anticonvulsant drugs. Then comes the high risk exposures like drugs, anticholinergic medications, and excessive alcohol consumption. And apart from alcohol consumption, with prolonged fasting, we have a lot of nutritional disturbances, which again predispose a person to have cognitive impairment. And then high risk behaviors like multiple sexual partners, IV drug users, predisposes a person to acquired chronic meningitis kind of infections like the neurosyphilis. Then exposure to a person having tuberculosis, and in a country endemic like India, even without exposure, it should, the tuberculosis, TB, meningitis should be high up in our list to be easily diagnosed and treatable. Then certain unexplained findings, like I talked about earlier, focal neurological deficits, like we see in SDH. SDH may not present with an acute hemiparesis like a stroke, but over a period of time, patient may just come with cognitive slowing, being not very alert as he generally was, becoming slow in activities, and then gradually decrease in the movement of one side of the body. And by the time that decrease in the movement is recognized, till that time the SDH has grown quite a bit, and when we do a CT scan, it is clearly evident. Similarly, other disorders like neoplasms, demyelinating disorders, and strategic vascular infarcts all may cause unexplained findings, which we do not generally expect in a case of neurodegenerative dementias, and easily diagnosed on a radiological investigation. Then incongruent cognitive testing means a patient who presents and says that I am totally defunct, I can't do anything, I can't remember anything. He has a lot of insight towards his disorder, that he is not able to perform his activities too well. But when you start testing him, doing an MMSE or cognitive assessment, you find that he's actually not that defunct. So at that time, we should consider that either he has a sensory deprivation, or he has a strong mood disorder, which needs to be recognized and corrected. So in these histories, these are all acquired causes that I have talked about, but fluctuations are well known in patients with dementia Lewy body also, and behavioral changes which we see in patients with mood disorders are also very common in behavioral variant of frontotemporal dementias. So after we have ruled out the reversible causes of dementias, and if we are not able to pinpoint any particular cause, then these disorders are actually also known to have fluctuations and behavioral disturbances. But that should be the last part, because early recognition of reversible causes is really important. So coming to the checklist, after we have narrowed down our search for the reversible cause, then we need to have a checklist to rule out any other causes that we may be missing. And I'll be elaborating about each one of them one by one, but just to list them out, uh, it is we can easily memorize it by dementia, the mnemonic dementia, where D stand for drugs, anticholinergic drugs, which are very commonly used in our clinical practices, especially for the elderly, for pain relief, for antihistaminic as an antihistaminic medication, or for urinary symptoms. Benzodiazepines, again, they are, even if they are not prescribed by any of the physicians, because of the easy availability of over the counter medication, people tend to buy medicine to induce sleep, and benzodiazepines over a long run, they cause a huge cognitive decline. And then polypharmacy, which is really common. Any patient coming above 60 coming to the OPD has a huge list of medication. They generally have a cardiac disorder, renal disorder, liver disorder, and every set of medicines is composed of like 5 to 6 medication, and in total they are invariably taking more medications than their food. That is their term, that we eat more medications than food throughout the day, and the drugs have a lot of interaction between them, leading to cognitive decline. Then E stand for eyes and ears, which indicates the sensory isolation. Any kind of visual impairment secondary to cataract, glaucoma, anything cuts them off from their environment. They are not actively involved, and subsequently they lead to cognitive decline. Similarly, if the hearing impairment, which is also very common in geriatric population, so the first thing that we need to ask the person coming with any kind of cognitive decline is whether he is able to hear properly or not. Then metabolic disorders, which are also very common in general population, include thyroid disorders, multiple vitamin deficiencies, especially in vegetarians, and then electrolyte disturbances, which are bound to happen with increasing age. Then we need to inquire about how a person feels. Does he actually feel depressed? And no, another common cause existing and frequently missed is normal pressure hydrocephalus, which is generally confused with Parkinson disease. But if you keep the triad in mind, even if all the three features are not present, it is very easily recognizable right from the point when the patient walks in the OPD. You can recognize a NPH gait and differentiate it from the PD gait, and it is also easily treatable by just doing a simple tap, and in the long run probably a shunt surgery. Then tumors and space occupying lesions, although they are very apparent in the radiological investigation, but sometimes they may be very tricky, which I would be elaborating by a case that we recently treated. Then chronic infections, which are also very prevalent in Indian setting, in which the HIV is the tuberculosis is the most common one, followed by HIV, and then neurosyphilis, and sometimes the case reports of cognitive decline associated with neurocysticercosis are also being mentioned. Then comes the autoimmune disorders, which are the most important ones because they are the most severe ones, and sleep apnea. The disordered sleep breathing, it has a huge impact on the cognitive facets of a person, and we should be very aware and make people aware regarding their sleep hygiene and whether at all they have any kind of sleep disordered breathing or not. So rather than going from D to S, I would be first taking up autoimmune encephalitis because I would like to stress upon some of the facts. So the most common, it is a common belief that autoimmune encephalitis happens in young patients. That is true, no denying the fact, but even in the age group of 17 to 45 years, if we see the data, neurodegenerative dementia still predominate even in this age group, although uncommon, but still the percentage of neurodegenerative dementias as a cause of dementia in 17 to 45 years is 31%, followed by autoimmune and inflammatory etiologies, not very far behind, but 21% of them are autoimmune. Still a significant population, but neurodegenerative dementias do occur in this age group as well. Immune mediated disorders, if we talk about India, then 18% cases of rapidly progressive dementia in India are contributed to immune mediated disorders. So some of the common perceptions that we have about autoimmune encephalitis are that they generally present with encephalopathy and seizures. Generally, what we have in our mind of a prototype of an autoimmune encephalitis case is the history, which should be around like 15 days. But sometimes the history of autoimmune encephalitis may stretch to up 3 and even to 6 months, and even more than that. They may just linger on as some subtle behavioral changes, and by the time we recognize it to be autoimmune encephalitis and autoimmune cause of dementia, the person may start throwing seizures and have an irreversible cognitive decline. So the fact is that they may present in the OPD with subacute to rapidly progressive dementia. It may not be necessarily a history dating to only a few days. It may date back to a few months as well. So predominantly they are seen in younger population, that is true, but up to 1/3 of autoimmune dementias in elderly may be misdiagnosed with an irreversible neurodegenerative disorder. And I think that would be a blunder in our part, that if any elderly suffering with an autoimmune dementia, if he gets misdiagnosed as an irreversible neurodegenerative disorder, then we have lost one person who could have been saved. And then negative antibody testing should not discourage a clinician towards treating an autoimmune etiology. Autoimmune disorders may have initial seronegativity, and the sensitivity also changes if we do it in the CSF versus the serum. But any kind of negative autoimmune etiology, but with a typical clinical course, should not discourage a clinician from giving it a trial of treatment, and they may occur even without accompanying autoantibodies. So these are the common autoimmune encephalitis. We are well aware with majority of the disorders, the most common one being NMDAR receptor antibody disease, in which is a part of limbic encephalitis. They generally present classically with psychosis, behavioral disturbances, seizures, encephalopathy, and cognitive decline. And if you see the percentage of cognitive impairment, they range. Most of the disorders have more than 50% chances of having cognitive impairment, and in some cases they may even be the presenting features. So autoimmune encephalitis should always be considered in a history of approximately a few months and associated with behavioral changes and cognitive impairment. But the point here to be noted is that in these limbic encephalitis kind of changes, where behavioral changes are the most common ones, sometimes we may tend to confuse it with the behavioral variant of FTD, as I said earlier. And in case of LGI1 disorders, in which there are faciobrachial dystonic seizures, these faciobrachial dystonic seizures, sometimes they may be very short lasting and may have a myoclonic quality to it, and may frequently be misdiagnosed as a case of CJD, which again is a non-treatable disorder, whereas LGI1 can be easily treated. So both the differential diagnosis should be kept in mind when we see any patient with a myoclonic kind of jerk, and we should actually be able to differentiate between a faciobrachial dystonic seizure versus a myoclonic seizure. And then comes progressive encephalopathy and rigidity myoclonus, which may present as a Parkinsonian disorder, but actually it is a glycine receptor antibody disorder, again treatable, whereas Parkinsonian features and Parkinson disease has an entirely different set of treatment, and these may not respond, and we may lose the window of treatment if the diagnosis is delayed for too long. Rest of the disorders we are very well acquainted with already. So I would just move on to the next slide. So I wanted to talk about the emerging clinical settings. We already know that autoimmune dementias are frequently associated with cancerous disorders, particularly teratomas, ovarian teratomas in females, and many other carcinomas like the small cell carcinoma of the lung. So paraneoplastic syndromes are very well known to be associated with autoimmune dementias, but there are some of the clinical settings where who are predisposed to having autoimmune dementias, and they should be kept in mind whenever we are dealing with any kind of patient with cognitive decline post these settings. So HSV encephalitis, in any patient treated for HSV encephalitis, and after an initial improvement, if he shows a relapse or a rapid worsening after initial improvement, apart from being a relapse of HSV encephalitis, autoimmunity should also be the second differential, and treatment should be offered accordingly. Then in post-transplant patients, we may paradoxically see autoimmune responses due to imbalances between T cell and B cell immunosuppressions. And a new concept that has recently come up are the immune checkpoint inhibitors. There are certain checkpoint proteins which stop the T cells to act on the normal cells of the body. So these checkpoint inhibitors, they act on those checkpoint proteins, and they facilitate the T cell to attack the abnormal tumor cells. So when these checkpoint inhibitors are often offered for any kind of carcinomas, then the excessive T cell response may generate an autoimmune response and lead to autoimmune reaction, which may lead to cognitive decline and cognitive dementias. So in this particular use of immune checkpoint inhibitors, the cognitive decline and this kind of autoimmune response may be seen up to 3 months to approximately an year after also the use of these immune checkpoint inhibitors. So past history of any carcinoma and their proper history of the proper treatment, that whatever they have received, is actually important. And wherever we know that these checkpoint inhibitors or any kind of chemotherapy has been used, autoimmune dementias should be thought of upon. the treatment of the autoimmune dementias secondary to these immune checkpoint inhibitor reaction is also similar to the traditional treatment of autoimmune dementias, which includes immunosuppression using high dose corticosteroids. And if they do not respond, then plasmapheresis and other kind of immunosuppressions can be offered, which work well in such conditions. So I would like to discuss and present two of our cases that we have treated. They were actually tricky and gave us a hard time, but under the guidance of Dr. Arun Shah sir, we were able to successfully treat them, and both of them are doing well. So first of them was a 71 years old female lady, professor by profession, and she was an extremely intellectual person who used to teach her grandchildren living abroad. That was the level of her functionality. But mind you, the age, she was 71 years old, and she had a cognitive decline since last 3 months, which was in the form of short-term memory loss. And gradually it kept on increasing, just the cognitive decline to begin with, and gradually it progressed, and she became dependent for her activities of daily living just because of the cognitive decline, so much so that she was not even able to maintain her hygiene for last 1 month. So from three in 2 months itself, she had progressed a lot to the extent of being dependent for 1 month. And by the time she had presented to her, she had become tremulous. She was very rigid, and we admitted her for further evaluation. And when she was admitted in the hospital, she got her first seizure episode, and she had significant behavioral changes. She did not recognize any of her attendants. She was very restless, very aggressive. So all these changes were the history and the clinical course was clearly deteriorating very fast in front of our eyes. So on examination, the comprehension was impaired. There was a poor registration recall, poor attention span, and not being able to do even simple calculations, which was really alarming for a person who was very functional before all this happened. So our differential diagnosis were automatically some kind of chronic meningitis. But when we did a CSF, so there was no cell, there were only 3 cells, but protein was high, which was indicating that there is some abnormal protein synthesis happening in the brain. But the second differential was autoimmune encephalitis, but the encephalitis panel came out to be negative. The third differential that we kept was CJD, but the MRI was not suggestive of CJD, neither was the EEG. And then finally, we were also thinking that because she was 71 years old, could it be probably, possibly a neurodegenerative disorder only, which showed a sudden drastic deterioration? That was the line of thought that we were working upon. Her EEG, MRI was normal, and because of cognitive decline, Parkinsonian kind of features, sleep disturbances, we also considered Igelon antibody disease, but it was also negative. So finally, we went ahead to the next step and we got a PET scan done, which showed a diffused increase uptake bilaterally in both basal ganglias, mesial temporal lobe, cerebellar peduncles, and hypometabolism of the cerebrum. So it was kind of indicative of autoimmune encephalitis. We went ahead with our hunch that it was indeed an autoimmune encephalitis and treated her with solumedrol. But to our disappointment, she did not even respond too well to solumedrol, although her behavior and all changed, but the cognitive faculties did not improve much. And she continued to have behavioral changes, some restlessness, rigidity was still there. So we gave her a trial of IVIG, to which she responded quite a bit. She became silent. She started recognizing her attendants. She started conversating a bit in a few words. And encouraged by this response, we again gave her IVIGs over repeated 2 doses every month. And when last time she had come to the OPD, she was absolutely mobile, walking independently. The rigidity had decreased quite a bit. She was initiating conversations, absolutely oriented. She had a trip to Delhi also, and she was doing quite well. So immunomodulation, but she was not as good as she was before all these things started. The level of functionality up to that level has not been achieved. So we had discussed immunomodulation with the attendants also, but that is what we are speculating. So we diagnosed her as a case of seronegative autoimmune encephalitis. So the message by presenting this case is that even if we are getting a seronegativity, but the other features fit in, we should go ahead and give a trial of treatment to such kind of patients. The other one was a 67 years old man, father of a doctor, And in contrast to the previous history, which was 3 months old, this was just a 3-day decline of cognition, behavioral changes. But we were called upon to look into proximal muscle weakness, which was found to be secondary to hypokalemia, and which recovered significantly after correction of hypokalemia, but the hypokalemia persisted. In the evaluation of hypokalemia, it was found that there was a high ACTH levels and positive DEXA suppression test. And it was thought that probably the patient has an endogenous Cushing syndrome, but the behavioral changes, restlessness, extreme aggressiveness, cognitive impairment was still not explained. There was also a history of renal cell carcinoma in 2018, which was treated with partial nephrectomy. So it was also thought that probably because of adrenals being removed, was it compensatory response of hyperaldosteronism kind of condition? MRI brain and pituitary were normal. And because the cognitive changes and the behavior changes persisted, we thought of autoimmune encephalitis, and we sent a panel, and which came out to be NMDAR positive. Now, this was baffling that whether this NMDAR positivity has anything to do with the Cushing syndrome. Was there an indolent neuroendocrinal tumor? Was the renal cell carcinoma? Because renal cell carcinomas are known to cause autoimmune encephalitis kind of condition. But this patient was already treated for the same 4 years back. Then now, was it a relapse? So to check for a relapse of renal cell carcinoma, we got a PET scan done, and he had typical changes of autoimmune encephalitis with occipital hypometabolism and adrenal hyperplasias. So we treated this patient with IVIG and plasmapheresis. One thing we were sure of was that he had NMDA encephalitis. So we treated with IVIG and plasmapheresis. He responded very well. And subsequent NMDAR antibody was once positive and last was negative. And he is doing very well cognitively. So this was all about autoimmune encephalitis and the conditions that might mimic it, and the way we need to go forward with the investigating the patients and how do we treat it. Then coming to the drugs, the most common cause of the drugs being causing cognitive impairment is polypharmacy. So nowadays, because super specialists are very easily available, so one single patient, he visits a numerous number of different specialities and has a list of medications from all of them. And the thing that we do not do is we do not check for the interactions of different drugs that may present, and they may harm the person in the long run. So elderly are particularly prone to adverse effect of polypharmacy because they have altered receptor sensitivity, they have decreased gastric motility, they have impaired renal and hepatic functions, decreased clearance, and all these things may cumulatively increase the concentration of drugs in their body and may act more than what they should in the common setting. The most common culprits of these disorders are the anticholinergic drugs. The other common ones are antidepressants, antipsychotics, antihistaminics, and bladder medication, which have antimuscarinic effect, but they also have an additional anticholinergic effects. And in addition to that, benzodiazepines, which are very regularly abused upon, they cause drowsiness, ataxia, confusion, and dementias. So wherever possible, the nortriptyline salts, the medication which have anticholinergic side effects, and benzodiazepines should be avoided as far as possible in elderly population. If anyone actually needs some kind of sedative or some kind of sleep inducing medication, then melatonin is a good option, which is a normal hormone which regularizes the sleep cycle and at the same time does not have any cognitive adverse effects and is not a hypnotic as such. And the other drugs that we neurologists tend to prescribe are valproate, topiramate, and all these drugs in the long run, when taken over a long period of time, because of their significant interaction with other medications, may also lead to cognitive impairment. So this is the list of drugs that are very commonly used, and they have a high anticholinergic potential and should be avoided as far as possible, and alternatives should be offered. Then correcting sensory deficits, approximately 1/3 of the people between 60 to 70 years of age and 80% above 85 years of age experience hearing loss. So whenever a person comes to the OPD, we must inquire about any kind of hearing impairment that he might be suffering upon. Even if they do not agree, but you feel that the person is not responding in your single command, then you should get an audiometry done and get it checked whether he has an hearing impairment or not. Not only logically does it indicates that the person may have cognitive decline, because if he is not able to hear, he is not able to register. If he is not registering, he is not forming any memory of the thing, and obviously he'll develop a cognitive decline. But it has also been seen in studies that both hearing and visual loss can be associated with permanent changes in the brain structure and increase the risk of dementia and cognitive decline. So any patient presenting with cognitive decline should be screened for sensory deficits, and correction should be provided, and only then we should go ahead and investigate for other causes of cognitive decline. Then comes the metabolic disturbances and nutritional factors. Thyroid hormones are very important hormones for myelination, for neurogenesis, synaptogenesis. They play a very important role in normal functioning of the neuronal milieu, and they exert important effects on the cognition and behavior, especially during the neural development. Thyroid diseases can also lead to depression, weight loss, and arrhythmia, all of which may cumulatively aggravate dementia. So the studies are lacking in which they actually attribute thyroid hormone as a sole cause of dementia, but it is a very important accompaniment of the increasing neurodegenerative disorder, and correcting thyroid status of a patient may actually improve on the cognitive functions of the patient. But whether at all it is entirely contributory to a cognitive decline or not is still not clear. But some of the disorders related to thyroid, like Hashimoto's thyroiditis, is an important cause of treatable and reversible dementia. But that too, we have to take it with a pinch of salt, because the diagnosis of Hashimoto's thyroiditis is dependent on anti-TPO antibodies, which may come out to be positive in a wide range in the elderly, and may not actually be always pathological. So we have to have a clinical impression, and if it is fitting in with abnormal thyroid function test as well as abnormal and very high anti-TPO antibodies, then they need to be corrected. So they are very steroid responsive, and that is why they are also called as steroid responsive autoimmune thyroid disorders. Apart from the thyroid disorders, other endocrinal disorders like Cushing disease, the case that I discussed earlier, that was a thought that whether Cushing disease is leading to impairment, but then the NMDA receptor antibody came out to be positive. So in the long run, it is thought that Cushing disease causes, it is seen and documented that Cushing's disease in long run can cause hippocampal atrophy as well. And electrolyte disturbances leads to fluctuation in sensorium and cognitive decline. Encephalopathies are also associated with uremia, dialysis disequilibrium syndrome, which we commonly see in our clinical settings in the ICUs, and hepatic encephalopathy. They are all associated with fluctuating, but up to a certain extent, by stabilizing their metabolic status, we can at least by some percent reverse their encephalopathy and cognitive decline. Then comes the nutritional disorders of treatable dementias. B12 deficiency is very common in Indian setup because of predominant vegetarian population. Folate, niacin are important for neuronal health. And deficiency of niacin, although uncommon, it results in severe cognitive impairment, which is easily recognizable due to the dermatological manifestations and show dramatic response to the treatment. So before I go to Wernicke's encephalopathy, I would like to share another case. This was a 57 years old man and had presented with forgetfulness since 3 years, with imbalance while walking and changes in behavior. He also had a history of chronic diarrhea and a significant weight loss. When he did not directly present to us, he was admitted to some outside hospital with this history, and sadly the clinical examination was overridden by the radiological findings, which is commonly seen in clinical settings with increasingly easily available radiological investigations. We tend to ignore our examination findings. So this ribboning was seen in the MRI, and it was labeled as a case of CGT. But sir could make the diagnosis in a blink by looking at the examination. He had an angular cheilosis and he had significant pigmentation. The diagnosis was straightforward. He was a case of pellagra, and he was supplemented with IV multivitamins, nicotinamide, cyanocobalamin. His initial MMSC was very low. He was totally obtunded. And now when he has come, he is an active LIC agent, and he is still working, and he's very actively involved in the share market as well. And apart from the reversal of the cognitive changes, he also had the reversal of his dermatological medications. So the message by presenting this case is that we should be very thorough with our clinical history and examination, and the MRI should not give us the diagnosis. It should be our clinical history and examination that should be giving us the diagnosis. And then the Wernicke's encephalopathy, it is not necessarily always associated with a history of alcoholism, just a poor nutritional intake, which may be secondary to excessive vomitings, which may be secondary to just prolonged fasting, which is seen commonly in certain sectors of populations. After that, also nutritional deficiencies should be taken into account. It characteristically presents with ophthalmoplegia, ataxia, delirium, but all the three may not be present. Either of them or two of them may be enough to diagnose as Wernicke's encephalopathy. If it is not treated on time, it may lead to a prolonged amnestic disorder, which is the Korsakoff syndrome, which has a characteristic confabulating and amnesia as its predominant features, in which the patient has anterograde amnesia more than the retrograde amnesia, but he is able to maintain a normal conversation because he has a lot of confabulation. That once a person reaches this stage, it becomes irreversible. Again, because of the history, it is easily recognizable and diagnosed, and the diagnosis is supported by MRI, by atrophy of mammillary bodies and hyperintensities around the sylvian aqueduct and in the diencephalon. And it is easily treatable by B12 supplementation, and once it is diagnosed, the B12 supplementation should be lifelong. Then comes depression and pseudodementias, which Dr. Ashutosh sir would be talking about in detail. Just to list up, it has severe memory disturbances with specific impairment of episodic memory. To recognize whether it is pseudodementia or dementia, the foremost clinical hint is that a person with depression comes on his own. He has insight and he says that he is not able to do anything. He has a very low cognitive reserve. Whereas a patient of dementia is generally brought upon by his attendants, and the attendants complain that the person is losing his memory and he is becoming increasingly forgetful. And when we assess the patient for cognitive decline, he can perform, a person with depression can perform much better on insistence, and he may not be within the pathological range in our formal testings. So that is the difference between depression, cognitive decline due to secondary to mood disorders, and cognitive decline secondary to dementias. And treatment of depression, they may coexist also, because some of the degenerative disorders have significant behavioral impairment. So we need to recognize that how much component of it would be treatable, and wherever possible, we should treat it and give the benefit to the patient. So treatment of depression may improve the quality of life, decrease institutionalization, and improve cognitive functions as well. Then comes the structural disorders. As I said earlier, normal pressure hydrocephalus is very easily diagnosed by the way a person walks, and the triad of cognitive decline, dementia, urinary incontinence, and ataxia. Ataxia is more of a frontal gait disorder. It is kind of gait apraxia, in which a person has apraxia. That means he forgets how to walk. He walks with a short step, but the difference between a Parkinsonian gait and a normal pressure hydrocephalus gait is that although the steps are short and they're magnetic, he cannot lift up the foot off the ground, but the gait is wide based in normal pressure hydrocephalus, whereas it is narrow based in Parkinsonian disorders. It has a significant prevalence above the age of 80 years, which is 5.9%. Again, I would like to stress that normal pressure hydrocephalus is a clinical diagnosis which is supported by investigations. It should not be diagnosed on the basis of MRI findings. Only when we have a typical gait and cognitive decline should we correlate it to the MRI and finally diagnose the patient to have normal pressure hydrocephalus. The cognitive impairment is somewhat different from Alzheimer's disease in the form that there is a severe impairment of frontal lobe functions with relative preservation of memory and orientation. Dramatic improvement follows after CSF improvement, but we have to do it timely. And once the neuronal pathways are permanently damaged because of hydrocephalus, we might not be able to achieve an optimal response even after CSF removal. So we had this case in which there was a 66-year-old man with magnetic gait and ventriculomegaly on MRI. His initial MMSE was 19, and after the TAP test, the MMSE was 28. So you can see the drastic response in his cognitive function pre and post TAP, and we highly recommended him a TAP surgery, which is yet to be done. Then there are, although the space occupying lesions are easy to diagnose because of focal neurological deficits, but sometimes it may be tricky, as was in this case in which there was a 70 years old doctor, doctor by profession, he was 70 and he had come with cognitive decline. At till the age of 70 also he was doing reporting of MRI and CT scans, and it was very baffling for the family that now suddenly he can't even report X-rays, he's making errors even in that. So there was a progressive cognitive decline, behavioral changes in which he had become withdrawn. He was talking irrelevantly. He was totally cut off from the surroundings, and there was no orientation. His MMSE at presentation was 18. His initial MRI looked like this. In 2021, there was a slight meningeal enhancement. Initial diagnosis was chronic meningitis. We tried a course of ATT along with steroids. Neurosarcoidosis was also considered initially. We could not do biopsy on the first go because there was no particular area from where we could have taken a biopsy. But since he did not respond to any of the treatments, and by November, the meningeal enhancement had increased significantly and he had cognitive decline, we went ahead with a biopsy and he was found to have a non-Hodgkin's lymphoma, B cell type. And when it was treated with cytarabine and dexamethasone and high dose methotrexate plus vincristine, his MMSE improved to 24. Just after the first cycle, just with a single cycle, his MMSE improved dramatically, and you can see the improvement in the MRI as well. This is a post chemo T2 flare and contrast. So whenever we have such cases where we are still in doubt, we should use our clinical acumen and we should not hesitate to offer advanced studies to be very sure of the diagnosis. But sometimes these cases may be tricky, maybe initially missed, but in the long run we should pursue and we should keep a look rather than just brushing them off as a neurodegenerative problem. Then comes the CNS infections, as I have been repeatedly highlighting: tuberculosis, HIV, and associated opportunistic infections associated with HIV, syphilis, Lyme disease. Whenever these infections are suspected, high-risk behavior and high-risk exposure should be inquired upon, especially in a case of syphilis, although not very common, but still dementia and spinal cord signs like paresis, sensory ataxias, blood bubble disturbances should be checked for. And the infections are easily diagnosed with the help of CSF investigation and other markers for infections, and treatment should be offered. Then comes the sleep apnea, which is cessation of breathing during sleeping for more than 10 seconds. Hypopnea index helps us out after a polysomnogram to look for if there are actually sleep apneas or not. And sleep apnea may not be an isolated entity, but it may be a significant contributor to the cognitive decline. And we should be very active in diagnosing wherever there is a typical morphology, and even when there's no typical morphology, but still if you get any signs of sleep apnea or any kind of excessive somnolence and retrognathia, thick tongue, short neck, then we must be actively investigating by a polysomnogram and giving correction by CPAP. I would not dare to talk more about it in the presence of Joy sir, and he would be elaborating more upon it. So just the last few slides, I would like to take this opportunity to talk about some lesser talked about reversible dementias. Till now, whatever I have talked about, we already know about most of those disorders. I just gave a brief account. But these disorders are not very well known, and they are being increasingly recognized. So we should be on high alert in diagnosing even these causes as a cause of reversible dementia. First one is CARI, cerebral amyloid angiopathy related inflammation. So what is CAA and how do we differentiate it from CARI? CAA is a degenerative disorder which has a pathology similar to the Alzheimer's disease. except that the amyloid beta deposition that happens in a CA is in the media and tunic adventitia of small vessels and medium-sized leptomeningeal and cortical blood vessels, whereas amyloid deposition is in the neuronal cells and brain cells in the Alzheimer's disease. It is also a long-drawn process, CAA, and which generally presents as focal neurological deficits secondary to in acute lobar hemorrhages. CAA can be diagnosed. There are a specific set of Boston criteria by which CAA can be diagnosed, but they also may present as a chronic progressive cognitive decline. There's no particular treatment for cerebral amyloid angiopathy as such, but once it is associated with inflammatory response to this amyloid beta deposition, that is when we call it CARI, CAA related inflammation. So that is treatable, and it presents not as a chronic progressive encephalopathy, but as a subacute cognitive decline with behavior changes, seizures, headache. And T2 weighted images help us out in the background of cortical microbleeds, superficial sidrosis, and SAH and cortical atrophy, on the background of which we see a T2 white matter hyperintense changes like these. We can see the T2 hyperintensities here with a background of many microbleeds in the SWI images. That is when we should consider CA related inflammation and treat it with immunosuppressants. But the point we made here is that not always these MRI findings are visible. It is again a clinical diagnosis, and the radiological investigations may present many months later, and the clinical manifestations may happen early. But looking at the other patterns like the small lacunar infarcts and chronic microbleeds with superficial cirrhosis and a remote cortical bleed, gives you a hint that it might be CAA related inflammation. So MRI helps in diagnosis that then amyloid PET scan may show amyloid deposits. As in Alzheimer's disease, it also has a predominance of ApoE4 allele mutations, and then finally histopathological correlations. So the differential diagnosis to be kept in mind while dealing with the case of CARI are PRES and CNS lymphomas, primary CNS angiitis, which can be easily differentiated by the fact that it is predominantly an amyloid pathology, and autoimmune encephalitis, venous sinus thrombosis, where we can easily rule it out by doing a venogram, and Hashimoto's encephalitis, neuropsychosis, etc. But the bottom line is timely diagnosis and early commencement of immunosuppressive therapy may help reverse the symptoms, and we should give the treatment, offer the treatment before it is too late. And sometimes if the treatment is delayed quite a lot, then we may not be able to salvage the patient at all. The other one is Igelon 5 disease, which is also, if you see the prevalence, it is just 12 in 1,05,000, 1,50,000 per year. But the low prevalence is not because it is not prevalent in the society, but because it is not very well diagnosed, it is not brought into light, and the awareness has to be there in diagnosing Igelon 5 disease early, because again, it is treatable when diagnosed early. So Igelon family of genes are involved in neuronal addition, neurogenesis, and neuroplasticity. The classical clinical features are sleep disorders, bulbar symptoms, gait abnormalities, and cognitive decline. The sleep disorders are predominantly in long sleep latency, and REM behavior disorders in which the patient may have violent jerking during sleep. Bulbar symptoms in the form of dysarthria, dysphagia. Gait abnormality in the form of Parkinson kind of gait in which freezing may predominate, and long-standing cognitive dysfunction. The other constituent of this syndrome are oculomotor abnormalities, dysautonomia, cerebellar signs, hyper and hypokinetic movement disorders in the form of chorea can be there, ataxia can be there. So when there are multiple systems involved in the form of extrapyramidal, pyramidal, Parkinsonian kind of features, along with sleep disturbances and bulbar symptoms, we should all club them together and think of Igelon 5 disease as well. The presence of the diagnosis is through Igelon 5 antibodies. It is not commercially very easily available, but it is done. And deposits of hypophosphorylated tau, mainly in the tegmentum of the brain and hypothalamus. So the tau deposits are mainly in the diencephalic area, that is the hypothalamus, which helps to differentiate it from PSP, where this area is paired. So it is generally triggered by some underlying infection. It also has a genetic predisposition in the form of HLA disorders, and serum and CSF antibodies are the mainstay of diagnosis. So it is also a twofold pathology in which there is some component of autoimmunity, and because of the deposition of tau, it is also a neurodegenerative process, and it manifests as in bulbar symptoms, sleep disorders, and gait abnormalities. So once we have diagnosed it with the antibody testing, polysomnography, and MRI, we can offer a combination of monotherapy or a combination of immunotherapy in the form of steroids, IVIG, and immunosuppressants like rituximab, azathioprine, and cyclophosphamide. So I've taken quite a lot of time, I think, but I would like to sum it up that neurodegenerative disorders still remain most common cause of dementia. They are progressive without any definitive treatment, but careful history and examination may point towards an alternative or additional diagnosis. Nutritional deficiencies, NPH, and endocrinal problems still remain the most common cause of reversible dementias, but autoimmune disorders should not be missed, and detailed investigations may be required depending upon the suspected cause. Treatable dementias may be untreatable after a delay in diagnosis, and early diagnosis and treatment is the key. Thank you so much, all of you, for patiently listening to me, and I hope I was able to add a little to your already existing vast sea of knowledge. Thank you.
Thank you, Dr. Ishu Goyal. Interesting cases which you showed.
Thank you.
And yeah, any questions from the panelists, or I'll take the questions of delegates? No questions. Acha, there is one question. Ma'am, 67-year-old man with 3-day history, can he be a patient of paraneoplastic syndrome?
Generally, the paraneoplastic syndromes do not have such an acute history, but if you have a strong clinical background, like a pre-existing already, if you know that the patient has a carcinoma in the background, the history may not be appropriate. You need to take the history more carefully, that whether it has flared up in the recent 3 days or it was pre-existing and subtle disorders were pre-existent and suddenly it has flared up because of some reason in the last 3 days. That could give you a clue whether it is a paraneoplastic syndrome or not. And paraneoplastic causes of autoimmune dementias can present within 3 days as well. So cognitive decline in the setting of a carcinoma with this history can be paraneoplastic, but then you have to take all the features into account. And if you don't have any specific strong background, you can just do a screen like an ultrasound or something before going ahead with PET scans and trying to find out underlying etiology in the form of cancer.
Recent memory loss vs past memory loss. Can you elaborate on the DD?
So commonly in the neurodegenerative disorders, the recent memory loss is the most common feature, in which the person is not able to form the memories of whatever has happened in the last few hours or in the last few days. Whereas in the past memory, that is a very late feature of very advanced dementias. So there are like practically most of the neurodegenerative as well as the acquired causes, they generally present with recent memory decline only. When they are very advanced, pretty advanced, then you tend to get past memory impairments as well. So majority of the causes that we generally come across present with recent memory loss only rather than past memory loss.
Okay, thank you, Dr. Ishu Goyal. Any other questions, or we move on to the next speaker? Our next speaker for today is Dr. Ashutosh Shah. I'll request Dr. Komal Jatania, member IMA CGP, to kindly introduce.
Thank you, Dr. Kajal. Good afternoon, everyone. Dr. Ashutosh Shah is a consultant in Psychiatry Department at Sir H.N. Reliance Foundation Hospital and Research Center. He did his MBBS from the University of Mumbai, followed by DPM and DNB in Psychiatry Medicine. Dr. Shah has worked at many prominent hospitals in the city and holds lifetime memberships of Indian Psychiatric Society, Bombay Psychiatric Society, General Practitioners Association, and Indian Society for Clinical Research. Dr. Shah has several publications at national and international levels to his credit. His special interests include mood and anxiety disorders, schizophrenia, dementia. Today, he will speak on late life depression and Alzheimer's disease, an ounce of prevention, a pound of cure. Welcome, Dr. Shah.
Thank you, Dr. Chaitanya. At the outset, I would like to thank the organizers of today's event, Sir H.N. Reliance Foundation Hospital, Neurology Department headed by Dr. Arun Shah Sir, and Indian Medical Association, Mumbai branch. So let me share my presentation. Let me know once it's visible, please, Dr. Chaitanya. Is my presentation visible for you?
Yes.
Okay, thank you very much. So I would like to start off by saying that I do not have any financial interest or potential conflict of interest in today's presentation. So now if we look over the last, I would say 70 years, the demographic pyramid of the world, we are seeing increasingly the life expectancy increasing from a median age of around 31.6 in the year 1950, all the way projected up to 2100. The median age is going to be as high as 41.6. And of course, slight predominance of women living longer than the men. At the same time, this is not equal. So there's an unequal distribution of the age. We see more people in Japan, European Union, as well as in Canada, aging much faster as compared to younger countries like Africa and also India. Now, the absolute prevalence of dementia has gone up. Over here, you see this blue line that has been adjusting for the impacts of population aging and changing age structure. And we see that there is definitely an uptick in the prevalence of Alzheimer's and other dementias over the last 3 decades. At the same time, the prevalence of people with depression globally, and on the top, we see India is heading this, is also the number of people with depression over the last 3 decades has gone up. And within the depressed people, there's larger share of chunk of people in the age groups 50 to 70 plus. You see 50 to 69 is having the higher prevalence of depression as compared to someone in the age group of 25 to 29. This is at the global level. And also for the elderly, 70 years and above. And India is not getting younger by the decades. We see all the way from 50, you see this green curve is going down. That's our young population. And as Dr. Arun Shah sir has already shown, we are going to be having a lot more gray hairs in our population in the coming decades and years. So why all this? It's because over here, it's on the top of the screen that we are expecting a lot number of cases of dementia world over, specifically in the lower middle income countries like India, as compared to the higher income countries. And why is that so? 2 possibilities which already Dr. Arun Shah touched upon. One is a better education of the population, and secondly is a better control of the vascular risk factors. So with this setting, let's see about the elderly. We know that depression and Alzheimer's disease are the 2 most common comorbid disorders in those age 65 and above. At the same time, depression at any age, be it early, mid, or late life, has been associated, that means statistically correlated, with an increased risk of Alzheimer's disease in several large prospective epidemiological studies. So in fact, a history of depression in any given individual actually doubles their risk of getting Alzheimer's. So with this kind of a high association, there has to be some amount of causational element as well, which I'll come to in the later part of my talk today. And a lot of it is also preventable. And we can say that depression is arguably a modifiable target for prevention of cognitive decline and dementia. So in the year 2020, the Lancet Commission report said that almost 30 to 40% of the cases of dementia are actually preventable. And this assumes much more significance in the light of the fact that we really do not have any disease modifying therapy today or any curative treatments available. So definitely a focus on prevention is going to be much more fruitful than actually looking for new cures. And depression at the population attributable risk factor is 4%. That means for every 4 individuals with depression, or rather every 100 individuals with dementia, if we were to treat depression aggressively, we would be preventing 4 dementias in out of 100. So that's a fairly huge number. So moving ahead, we know that depression as a symptom could be prevalent in almost a third to half of the patients of Alzheimer's. And as a syndrome, a full-blown episode in almost 10% of the people with Alzheimer's, and much more, almost half of them with vascular dementia. The definition of the terms depression and dementia are heterogeneous with blurred boundaries. So what do I mean by this? So first of all, everybody should make it clear today that depression is not a diagnosis. It's just a symptom. Same goes for dementia. Dementia is nothing but a symptom. It's not a diagnosis. The underlying causes are myriad. Actually, dementia, it's now replaced by the term neurocognitive disorders in your classification system, but it's actually a proteinopathy. And the symptoms, let's say, of apathy, sleep disturbances, anxiety, depression, they are both common to both these particular disorders. So there is no definitive distinction. In fact, we should not be having a dichotomous approach that is this depression or is this dementia. We can jolly well have a coexistence of both of these, and depression can be considered as a symptom of dementia itself. So with this particular introduction, what are the questions that I'll be trying to attempt to answer over the next 20-25 minutes? A, what is the relation between depression and dementia? And does depression cause dementia? And I'll be spending a fair large amount of time on this particular question, followed by what is the consequence of Alzheimer's disease neuropathologic change on depression treatment? And finally, could treating late life depression prevent cognitive decline in depressed individuals and prevent dementia? So coming to the first question, what is the relation between depression and dementia, and does depression cause dementia? So first of all, let's see, depression can occur on the left-hand side, you will see on the top, as an episode predating the onset of Alzheimer's disease and could truly be a risk factor. Or it can be an early sign or a prodrome of dementia and Alzheimer's disease, or it can occur during the later stage of Alzheimer's disease. Now, no matter when it occurs, the occurrence of depression itself would accelerate the onset of cognitive decline. So a person may go into minimal cognitive impairment and then subsequently into full-blown dementia simply because of the presence of depression. Or the point is, the depression can actually accelerate the decline when a person is already having Alzheimer's from moderate to severe intensity. And how that could possibly be happening is explained on the right side, where we see in depression, we have a HPA axis dysregulation. We have a reduction in several nerve growth factors. And what these two pathophysiological entities do is they contribute to amyloid deposition, tau aggregation, and degeneration of neurons, which are the hallmarks of any degenerative illnesses, specifically Alzheimer's disease. And also neuroinflammation, which is common to both dementias as well as Alzheimer's, would further aggravate this. So we see that the relationship of depression and dementia in this particular slide is quite interlinked. Now, the other potential relationships between these two particular entities, I'm not going to be reading out the slide over here, but what I'll be focusing on is the last component, that is depression and dementia share a common pathoetiology. And of these, there are 10 proposed hypotheses. I'm not going to go into details of all these 10, just touch superficially on the first two, that is endocrine hypothesis and neuroinflammation hypothesis. So looking at endocrine hypothesis, what is already well known within people with depression is the HPA axis dysregulation, standing for hypothalamic pituitary adrenal axis dysregulation. And what happens is almost in 70% of the people with depression, there's a downregulation of the glucocorticoid receptor. And what that leads to is an impaired negative feedback loop, leading to a hypercortisolemia. So excess of cortisol and a decreased responsiveness to glucocorticoids, what does this do? This leads to an increase in the expression of the amyloid precursor protein, which in turn leads to a deposition of the amyloid. Secondly, what happens is there's an alteration in the tau phosphorylation state. So what does that mean? The tau proteins are hyperphosphorylated, and within the neurons, that leads to the tau aggregation and neurofibrillary tangles. And thirdly, there's a reduction of various nerve growth factors. The prominent example is the BDNF, but there are at least another 100 which are also involved, like vascular endothelial growth factors. And what does this do? This suppresses the formation of new neurons, that is neurogenesis is reduced, and also toxic processes within the brain, which lead to hippocampal cell injury and neuronal cell death, contributing to neurodegeneration. So we see that depression and dementia are interconnected at the molecular level through the particular diagram I've just explained to you. So having seen the endocrine hypothesis, let's touch base on the neuroinflammation hypothesis. So what happens over here is, within depression, a subset of individuals are hypothesized to have ongoing neuroinflammation. What exactly is the cause, whether inflammation is a result of some other pathology or is leading to another pathology, is not yet known. But a central or a peripheral inflammation leads to an activation of the microglial cells within the brain. And also on the top over here, you'll see the metabolism of tryptophan is altered. So a deficiency of the monoamines, tryptophan and dopamine happens. The indolamine oxidase, IDO metabolism, the kynurenine pathway within the cells is shifted from producing kynuric acid, which is a product which gives nourishment to the neurons, to formation of quinolinic acid, which is actually neurotoxic. It hampers the functioning of the NMDA receptors, and via glutamate toxicity leads to neuronal cell death. This is what is happening in depression. So what happens? How does it translate? So all this low-grade inflammation, as well as the reduction in the anti-inflammatory factors and the activation of not only microglia, also the astroglia, leads to a modulation of the amyloid precursor protein, and that in turn leads to a deposition of amyloids and excessive accumulation of the beta amyloids. Other than that, again, a hyperphosphorylation leading to tau aggregation. And again, the same issue, reduction of the nerve growth factors and reduction of neurogenesis and structural and functional damage to neurons, leading to neurodegeneration. So all these three are the hallmarks of the pathological changes in Alzheimer's. So this is another hypothesis which interlinks the depression with the dementia. So of all these hypotheses, there is no universal agreement. And I wouldn't expect also that to be happening, because depression is a highly heterogeneous condition, and so also is dementia. So you cannot have one hypothesis explaining everything. Having seen this, let's come to the clinical evidence. And when we look at association studies, you'll get a lot of conflicting data. And in order to keep things simple, I've just taken out the references of the last 29 months. And on this screen, the left side, you will see this particular study finding that only a recent history of depression was associated with a higher risk of Alzheimer's, and that too in women only. On the right side, this study found that the risk of incident dementia varied with the presence and resolution of depression at different ages. So very contradictory findings. Another one found that early onset dementia, EOD stands for early onset dementia, that means dementia beginning before the age of 60. These folks did not experience a rapid decline as compared to the never depressed cohort. And the late onset dementia, that means late onset depression, that means depression occurring after the age of 60, resulted in a rapid decline in verbal skills and delayed memory. And this paper, which is yet to be published, the manuscript has been accepted in the Journal of Biological Psychiatry. This found a prospective cohort study of more than 3.5 lakh participants, found that depression was associated with a 51% higher risk of dementia. And they also subcategorized the different trajectories of depression over the course of a decade in this cohort. And what they found was those with increasing chronically high, chronically low courses were actually associated with a higher increased dementia risk, but no association found in the decreasing course. That means once the depression is treated, the risk was decreasing for developing dementias. And that can be shown graphically over here. In the black is the people who have never experienced depression versus those who had experienced depression. And these people were at a 51% higher risk for developing dementia. Of course, these are all the Kaplan-Meier estimates, not actual things. And on the right side, those who were never treated, those who never had depression had a lower risk, as also those who had a decreasing, that means after treatment, a decreasing intensity of the depressive symptoms. The maximum risk was those who were having increasing trajectory of depressive symptoms over time, as well as intensity, followed by those who had chronically low and chronically high intensity of symptoms. So all this, and then this umbrella review of distribution of modifiable risk factors throughout the course of life. So this appeared in the Journal of Affective Disorders, and it will be coming out in the next month. And what this umbrella review has done is it has studied more than 118 systematic reviews and meta-analysis and looked at 243 factors associated with depression and dementia. And what they have categorized is the level of evidence into convincing, highly suggestive, and suggestive throughout the course of life, be it early life, midlife to late life, and late life. So convincing, when there was a large number of studies, a very good population sample size, where the odds ratio did not cross the null, and this would be labeled as convincing evidence. And we see in late life, depression over here has been associated very highly with both all-cause dementia as well as Alzheimer's dementia. And I will take this opportunity to actually highlight another finding from this is current use of benzodiazepine or ever benzodiazepine use, which also was mentioned in the slide set by Dr. Ishu Goel. And therefore, I will take this opportunity to remind all practitioners, please avoid using benzodiazepine and be very judicious when using benzodiazepine in your patient population. If they're coming to you with sleep disturbances, please figure out what is the root cause of this instead of a knee-jerk reaction, often due to a pressure from the patient to prescribe benzodiazepines. Because once we prescribe, the patients are hooked on for the rest of their life to benzodiazepines. And it's almost impossible in the elderly to knock out the benzodiazepines. And that really actually worsens the dementia when the benzodiazepine use is already there. So having seen all this association studies, thanks to WhatsApp, I got this particular photograph. You see a cat sitting on this shed. It doesn't mean cat was responsible for this particular event happening or the shed being destroyed. It is just a correlation. Incidentally, the cat happens to be there. Whether it came after the shed broke down, before the shed broke down, we don't know. So that is the main drawback of randomized controlled trials, which is actually overcome by what is known as the genome-wide association studies, as well as the Mendelian randomization studies, which can actually pinpoint and give you a causational etiology. And that is what I'm going to explain in the next one. And this particular paper, which is just released 2 months back in Biological Psychiatry, results of which were widespread announced in the end of Q1 of this year, has actually given the first genetic evidence for contribution of depression to Alzheimer's disease. And what the authors have done, the lead author, Nadia Hariri-Mana, is a neurologist. And this entire team was a teamwork of neurologists, biochemists, geneticists, and psychiatrists. And what they have done is they have done 2 genome-wide association studies which are already existing in depression and dementia. And they have done a reanalysis and found a small but significant genetic correlation between depression and Alzheimer's disease, suggesting that there is a shared genetic basis. And the predominant genetic evidence is consistent with the causal role of depression on Alzheimer's, but not vice versa. And for this, they have done a Mendelian randomization study in the one cohort and then rechecked it with a separate cohort. So depression precedes and is genetically associated with the causation of Alzheimer's. And that is what these authors have found. Apart from this, they identified, so they also did proteomic studies, and they found 75 brain transcripts and 28 brain proteins, which are regulated by this depression predisposing genetic variants. And of these, they found that 46 transcripts and 7 proteins were associated with either a diagnosis of Alzheimer's or the pathologies, either beta amyloid or the tau neurofibril tangles, or a declining cognitive trajectory. And they also found that a higher depression polygenic risk score was associated with a faster decline of memory over time. And all these 46 brain transcripts and 7 brain proteins could likely be contributing to the association between depression and higher Alzheimer's disease risk. And pictorially, this is what the study has done. They found a genetic depression risk, which leading to depression and then to Alzheimer's. And of course, this Mendelian randomization removes the confounders, and therefore we can get a causational etiology. At the same time, they did proteomic studies, quantitative associations over here, and they found that the depression genetic risk leading to RNA proteins affecting the amyloid beta and tau, as well as cognitive decline, and then leading to dementia. So the 2 proteins out of the 7, specifically RAP27B and DDH2, were notable for their consistent association with all 4 features of Alzheimer's. And in this statistical heat map, these are the 2 particular proteins. And you see they are strongly associated with formation of beta amyloid, tau tangles, Alzheimer's diagnosis, and a declining cognitive trajectory. And a little bit brief insights into these two proteins. The RAP27B regulates membrane trafficking. It's a GTPase and is implicated in neurodegenerative disease. And there has been evidence that this is upregulated in the basal forebrain cells, specifically the cholinergic basal forebrain neurons of patients having an Alzheimer's. Of course, this is on a postmortem analysis. And the DDAH2 is responsible for a homeostatic control of nitric oxide across different tissues as well as in the CNS. And another study has found that in patients with Alzheimer's, this DDAH2 was elevated in neurons undergoing oxidative stress, and it was not detectable in the neurons of age-matched healthy controls. So having seen all this evidence, we have seen there is a strong statistical correlation between having a history of depression and an increased odds of getting Alzheimer's dementia or all-cause dementias, as well as the latest genetic evidence, which is pointing that depression is causally contributing to the development of Alzheimer's. We shift to the next question. That is, what is the consequence of Alzheimer's disease neuropathologic changes on depressive treatments? And for this paper by Taylor et al., which came out last year, will be of use. And what this study has addressed is, does a cortical amyloid burden affect the response to an antidepressant medication in patients with late life depression who are still cognitively intact when screened? And what they found was the high amyloid burden was associated with a poor response and failure to achieve remission with sequential antidepressant treatment. Of course, this means that cortical amyloid could contribute to antidepressant treatment resistance in late life depression. One of the main limiting thing about this study was the sample size. An overall sample size was just 27, of which only 5 patients had a high amyloid burden. So in a nutshell, this was just the preliminary evidence, the first of its kind study coming up. And therefore, we still need much more studies to have this particular thing reconfirmed. But also, already know depression, when they are given donepezil with an antidepressant, their depression improves even if they are cognitively intact on screening. So possibly in the future, when we have more robust medications available which are truly disease modifying, we can think of combining them with antidepressants in patients presenting to us with depression and not yet having a cognitive decline, in order to prevent a progression to a full-blown Alzheimer's or other causes of dementia. So having seen this second question, we come to the final question of today's presentation, is could treating late life depression prevent cognitive decline in depressed individuals and prevent dementia? So over here, I come back to this prospective cohort study, which is yet to be published, but the manuscript is accepted. And we see these trajectories that people who were not treated versus those who were treated, you can clearly see that the risk of dementia was high. The other point is, what kind of treatment? Was it pharmacological, psychotherapy, or a combination? Irrespective of whatever it was, it reduced the odds. Of course, pharmacotherapy was having much more beneficial effects, a harm reduction of almost 0.77. That means 77% reduction in the risk of developing dementia. And that is what actually was found, that patients with depression versus those who did not receive any treatment for the depression, they had a lower risk of dementia. And already we know that antidepressants not only reduce the depressive symptoms, but they decrease the risk of dementia. And this is coming from several observational and experimental studies. And how is that possible? So antidepressants have neuroprotective actions via anti-inflammatory action, stimulating neurogenesis, enhancing synaptic plasticity, reducing the amyloid plaque burden, as well as reducing the tau hyperphosphorylation. I'm not going to be detailing this for the paucity of time, but for those interested, they can take a screenshot of this table, which I've just summarized on the left, and various antidepressants. Of course, this does not happen overnight. It needs a minimum of 6 weeks to almost beyond 6 months for these actions to kick in. So I will also take this opportunity to correct one thing which was pointed out by Dr. Ishu. Of course, that was a confounding variable. So the fact that somebody had dementia with an ongoing antidepressant, a lot of correlational evidence contorts it to say that antidepressants are associated with dementia. It's not true. Antidepressants are actually protective against dementia. So having seen all this, my concluding slide, so far, mood and cognitive symptoms are often evaluated and treated distinctly in silos, possibly by different specialists. And given the evidence, increasing evidence of shared neurobiological basis, it really calls for a change in the approach, both in research and in our practice. From today itself, if you are having an individual, specifically an elderly individual, coming to you presenting only mood symptoms, please view this as a potential dementia in the future and treat aggressively. In practice, other than this, we should not be splitting hairs. Is this pseudo dementia? Is this dementia? Just take this. This could be jolly well the beginning of dementia with depression as the first symptom. The other thing in research, what needs to change is for those who are into research, for dementia trials, do not exclude people having baseline depression. And for those doing trials with depression, the endpoint should actually be cognitive decline as well as the onset of dementia. And the last thing is, needless to say, early recognition and appropriate and aggressive treatment of depression could potentially prevent dementia. So a little bit recap. Today in 2018, the global prevalence of dementia was 50 million. That means 5 crores. And if we say that treating depression could potentially prevent 4% of this dementia cases, we are looking at a huge number. 20 lakh cases of dementia potentially preventable by addressing early on depression at any stage of life, but specifically in mid to late life. Other than this, please remember both depression and dementia are the number one leading cause for disability adjusted life years for a high economic burden. So in the USA alone in 2018, the cost of dementia was 1 trillion. That means 1 followed by 12 zeros US dollars, projected to increase to 2 trillion by 2030. So by preventing the onset of dementia, we are saving money for the individual, for the family, for the society, and for the world. And of course, I'm not even touching base on the unspoken misery which the people undergo because of dementia. So if we can recognize depression, prevent it from progressing to dementia, we can truly say that an ounce of prevention may truly be worth a pound of cure. I thank you very much for your attention, ladies and gentlemen. That's all from my side.
Thank you, Dr. Ashutosh Shah, for the good presentation. Any questions from the panelists?
Hi, Dr. Kashyap here. Just one quick question.
Please go
Would
ahead.
a non-pharmacological approach be superior to pharmacological approach in the prevention of depression and hence dementia? So non-pharmacological, any superiority versus pharmacological?
So Dr. Kashyap, there is not, to my awareness, a literature which has compared this. So this prospective cohort study of 3.5 lakh individuals has actually seen that both psychotherapy as well as pharmacotherapy are associated with a harm reduction. And the difference is not very drastically different. With pharmacotherapy, the harm reduction is 0.77. With psychotherapy, it's 0.72. And with a combination, it's even better. Okay, so there is not to my knowledge, but of course, I would like to point out that if a disorder is biological in origin, without doubt, one should not hesitate to start pharmacotherapy. So accepting benzodiazepines, give any antidepressant that you are well versed with, the patients would improve. In fact, even this study has shown that tricyclics with high anticholinergic side effects were not necessarily related with a deterioration of the cognitive functioning. Of course, their improvement was lesser as compared to an SSRI. Yes, Dr. Joy.
Yeah, hi, wonderful
you.
talk. I really enjoyed that.
Thank you.
Would you share some thoughts on lifestyle measures to reduce the risk of dementia or depression in as we grow older? So do you think there is a role for mindfulness, for exercise, for exposure to nature, and whatever else thoughts you have in what should I do in my lifestyle so that I don't need the pharmacotherapy that actually works?
Okay. So I will take it this way, Dr. Joy. I mean, I know you like to be addressed as Joy, but for formality, I'll address you as Dr. Joy for this presentation. So let me go back to the slide deck, which Dr. Arun Shah sir had shown. We have modifiable risk factors and the non-modifiable risk factors, which in the case of dementia was age, gender, and a genetic component. So same goes with depression also. So there are non-modifiable risk factors, and the heritability of having a genetic predisposition is only 40 to 45% in depression, which means the remaining is actually a gene environment interaction. So that means that the individual has the potential to at least delay the onset of a depressive episode. And this is where lifestyle, and 4 things within lifestyle that I would like to point out. Without doubt, a healthy diet. So when I say healthy diet, I often tell my patients, what is good for your heart? And everybody says, yes, I know what is good for my heart. And I tell them that's exactly good for your brain. So just continue the same diet until unless you need a special diet because you are hypertensive or diabetic or having kidney problems or liver problems. The second thing is good sleep. Unless you are endowed with genes and you are a short sleeper, you should not be challenging what nature has already told us is to go to bed and at least have 6 to 8 or preferably 7 to 8 hours of uninterrupted sleep. And I don't want to encroach on what you are already going to say and say much more than what I know. So sleep definitely is beneficial. And third thing is the role of exercise. And I heard Dr. Contractor give excellent insights. I would like to add few points. You see, from an evolutionary perspective, if we look, we are really seeing 2 things coming up. As human beings, we are quite puny creatures, but as a collective cohort, we are quite strong. So our ancestors, the cave-dwelling ancestors, used to hunt using our brain and our muscles. So they would then gather the food for everybody to share. So this called for 2 things to happen. One was the social cohesiveness, and that is why a lot of our prefrontal cortex is actually for having social relation. And second is the muscular interaction between our muscles and our brain. In fact, when we exercise our muscles, we are releasing a lot of nerve growth factors for our brain. And there's a separate topic which we can have is the brain-bone axis. In fact, there is a brain-gut axis, there's a brain-liver axis, there's a brain-skin axis, there's a brain-bone axis. And whenever we are exercising our bones, our muscles, we are providing nourishment for our brain. So this is just getting to be kind of discovered. And the 4th lifestyle factor is stay away from all things which are neurotoxic, alcohol, all street drugs of abuse, benzodiazepines, etc. So this does not happen overnight. So you see, development of atherosclerosis takes at least 1 to 2 decades. Same goes for all this lifestyle risk factors. And the way I tell my patients is, as child, we used to have this piggy bank where you kept on adding a rupee or 5 rupee, or I don't know what today's children keep on adding. And eventually at the end of 10, 20 years, you have a sufficient corpus. Same goes with lifestyle. So there is never too late to start it, but do not expect miracles. You may do yoga, you may do meditation, but please remember, yoga, meditation, and other things have a role in preventing that too over decades. So tomorrow, if you want to do yoga for treating your depression, it is unrealistic because the quantum of yoga you need to do will exceed 24 hours in a day. Only then yoga will have that benefit as an antidepressant. But as an add-on to pharmacotherapy, definitely it is recommended. So please have this particular clarity in thought that if you're doing a lifestyle modification, it's not replacing the need if one already has an episode of depression. And if one does not have, one needs to continue this. Consistency is the key, not how much they do it. That is the bottom line.
Great. Thank you.
Okay. Thank you, Dr. Ashutosh Shah. Now, moving. Any other questions? Okay. The next speaker for today is Dr. Karishma Jethmalani. I'll request Dr. Sarita Devi to kindly introduce the speaker.
Good afternoon, everyone. Dr. Karishma Jethmalani is a neuropsychologist at Sir H.N. Reliance Foundation Hospital and Research Center. She did her MBBS from Anglia Ruskin University in Psychology and MSc in Cognitive and Clinical Neuroscience from Anglia Ruskin University, UK. She has various licenses and certifications in positive psychiatry and mental health and has several publications at the national and international level to her credit. Her current work involves neuropsychological testing and cognitive rehabilitation in neurodegenerative disorders and acquired brain injury. Dr. Karishma also runs a memory school at the hospital for people in early stages of dementia. Today, she will speak on brain exercises for dementia. Welcome, ma'am.
Hello.
Yeah.
I'll just share my screen just a moment. Right. So, hello all. I am Karishma Jetmalani, and I'm a neuropsychologist in Reliance Hospital. And my topic for today is exploring non-pharmacological treatment options for dementia, and most importantly, slowing down cognitive decline and preventing this progression, specifically from mild cognitive impairment to dementia. So to begin with, I'm just going to give you a brief introduction on what is mild cognitive impairment, also known as MCI. I know Dr. Arun Shah has given an introduction on this, but I would quickly like to brush up on a few points. So mild cognitive impairment is a condition that is just more than normal forgetfulness that can come with aging, but yet it is not to the level of a diagnosable dementia. So a mild cognitive impairment is critically a preclinical and a proximal risk factor for Alzheimer's disease or any other sort of dementia. Now, a person with mild cognitive impairment is able to perform all their activities of daily living and is able to function normally in all spheres of life. But they and their relatives may kind of notice these problems with their memory, their attention, their mood, possibly their thinking may have become a little rigid, and they may be prone to repeating themselves more often. Now, people with MCI are at an increased risk for developing a full-blown dementia or any other dementia, and it may be, a very sort of early stage of dementia. So now let's look and explore some data. The new MCI treatment guidelines from the American Neurology Association in 2018 suggested that globally more than 6% of the people in their 60s have had MCI, and about the number climbed to 37% by the age of 85. The guidelines further suggested that MCI cases progress to a full-blown dementia about 15% of the time among people who are 65 or older. And this progression is much more likely if there could be a there could be a progression to a new neurodegenerative disease such as Alzheimer's disease. But the question is that how long does it take for MCI to progress to a full-blown dementia? So if it is an amnestic mild cognitive impairment that could possibly lead to an Alzheimer's disease, it may take about around 2 to 5 years for it to progress. But I have seen patients stay in the MCI stage for a very long period of time with possible, lifestyle changes and cognitive interventions. Hence, there's an urgent need to develop effective interventions to improve the cognitive abilities of these people in the MCI stage so they don't progress to the dementia stage very soon. Now, let's explore some proven ways to treat MCI. So let's try to look at some evidence-based research here. Now, in the same study that was mentioned before from the American Association of Neurology in 2018, this study suggested that currently there is no evidence of any sort of pharmacological treatment that works for MCI at this stage. However, they suggested that two non-pharmacological treatment works really well, and it has sort of mild to moderate evidence, which is exercise training that Dr. Contractor has already spoken about, and cognitive retraining. can improve cognitive function and can prevent this sort of, can then halt this sort of delay progression to dementia. Another paper that was that suggested that there was moderate evidence for again exercises and cognitive training, and this paper by Lang and colleagues basically supported their claim. So now let's look at how can we protect our brain from this sort of cognitive decline. Before proceeding, I would like to highlight the importance of treating reversible causes that Dr. Ishu has beautifully highlighted, but I'll just like to kind of brush through them. So it's very important to regularly visit your physician and check for conditions like high blood pressure, diabetes, depression, sleep apnea, as these conditions could have an impact on your memory and overall mental functions. Latest research, again, like Dr. Ishu mentioned, that evaluating your hearing problem after a certain age is also very, very crucial, as developing a hearing problem can impact your attentional abilities and can progressively kind of cause a decline in your attentional abilities, which can then in turn affect your memory and can then lead to a permanent problem. So moving on, I'm just going to quickly run through some other preventive strategies and lifestyle modifications before moving on to the main approach, which I'm here to talk about, that is cognitive training or the brain training exercises. So first, we're going to talk about healthy eating. Now, there are a lot of research papers that suggest the importance of diet in dementia. However, it's not very clear that exactly what kind of diet actually works well with this condition. So a recent study in 2021 by Guterres and colleagues suggested that the MIND diet, which is essentially a Mediterranean diet, showed promising results. And that's a good place to start with. Next, we have the importance of exercising that Dr. Contractor again beautifully highlighted. Now, exercising is an approach that is consistently very promising. And like Dr. Contractor said, that training, like exercising even bi-weekly for 6 months can have a positive effect. And there have been several research studies on this sort of approach as well. There was a study done by Suzuki and colleagues back in 2013 that suggested that just generic kind of exercises for 90 minutes a week could reduce brain atrophy and could improve cognitive outcomes. Whereas another randomized controlled trial in 2012 suggested that resistance training is something that works really well to preserve cognition. A sensible approach is to include all sorts of important exercises, that is aerobics, resistance, training, balance, flexibility exercises like yoga. And although it may not be clear which exercises work the best for MCI, all four are necessary to maintain good health and mobility in older adults. Now, next we have the importance of social connections. Now, a number of longitudinal studies in the past have shown that an extensive social network may protect the brain against dementia. It was also suggested in previous studies that individuals living alone with friends or relatives seem more at a risk of developing dementia than people who had a spouse and family. This was especially relevant during the COVID times. We have noticed that during COVID, we've seen this surge in people getting dementia diagnosis, or we have seen certain conditions accelerating, sooner than we expect. And a condition like socializing, a normal skill like socializing can have, multiple effects and can be very beneficial to maintaining these cognitive reserves. So just a simple act like socializing, just going and meeting somebody can recruit your motor functions. Talking to somebody recruits your expressive language. Listening to somebody recruits your attentional abilities, your receptive abilities. Solving somebody's problem kind of recruits those problem-solving logical areas of the brain. And And reminiscing about the past sort of activates this remote memory center of the brain. So just by the simple activity, you can recruit a lot of other regions of the brain. Now, next we have novel skill learning. Now, novel skill learning or new skill learning has gained a lot of traction in recent years. Novel skill learning recruits the theory of neuroplasticity, which is essentially the process of maintaining, repairing, and creating new neuronal connections in the brain. It basically assumes that your brain, just like any other part of your body, is like a muscle, and each individual areas can be trained. So the principle goes like, if you lose it, if you don't use it, you lose it, and if you use it, you can improve it. So novelty and change basically activate neuroplasticity and activates these new neural pathways in the brain. So when we do the same things the same way, we only strengthen existing pathways in the brain. And this could be sort of, over-reliance on routine. And changing a routine does not involve a lot of drastic changes. Perhaps some days you read the newspaper. You can read the newspaper in your kitchen or in your terrace. So you can go down to a cafe or restaurant and read a newspaper with a breakfast. So these small kind of modifications in your day, these small deviations could add novelty to your life. Now, just to support this claim, I'm going to talk about a research study that's been published on this in Psychological Sciences back in 2013. So this study basically examined adults aged between 60 to 90, and they were assigned to either two groups. So one group kind of learned a complex skill like digital photography or quilting, while the other group indulged in crossword puzzles and Sudoku. Now, this intervention was carried out for 3 months. And at the end of 3 months, the study showed that the complex skill group, which was the novel learning group, showed wide range improvements in overall memory as compared to the crossword puzzle group. So basically, this study shows the importance of novel skill learning on delaying cognitive decline. Next is the main approach that I'm here to talk about, called the cognitive or the brain training games. A lot of research has suggested that that current and early life engagement in cognitively stimulating activities was shown to independently slow cognitive decline. And this was a paper published by Dr. Barbara Wilson and colleagues in 2013. It is also stated that cognitive activities may provide protection against decline and may help preserve cognitive function sometimes despite the presence of a pathology. Earlier, we thought that there was no treatment for dementia, but more and more studies are now justifying the importance of non-pharmacological treatment, particularly cognitive retraining on delaying progression. And just like novel skill learning, this sort of cognitive training or brain training relies on the theory of neuroplasticity, which assumes that the brain is a muscle, just to reiterate, and each individual areas can be targeted via certain activities. So now let's review some research and some benefits of cognitive retraining on the brain. So far there has been mixed research on whether a brain training program can help slow a memory decline. However, there has been a recent study that found that brain training can help people with MCI. And this was a study conducted by Jones in 2018. So in this study, participants recruited a total of 145 participants who were diagnosed with MCI. And these participants were split into 3 groups. The first group underwent 2 hours of brain training every single week for 2 months. The training focused on improving memory by learning new strategies to build for better encoding. For example, they remembered errands by associating tasks with specific locations in the home, also known as the method of loci or memory palace. They were taught other strategies like mnemonic training. They indulged in brain training activities as well. The second group in this study received again 2 hours of treatment, but they were taught how to focus on the positive aspects of life, like learning how to cope with stress and frustration. And the third group didn't follow any program. And all the participants were given a memory test to complete at the baseline and the follow-up of the study. The results showed that the people in the brain training group scored 2 to 4 times higher on the test than in the other two groups, where they showed a much smaller improvement. Right. Now, in recent years, a lot of computerized cognitive training has gained traction because of its safety and affordability. However, a lot of studies done on this topic, primarily when we talk about brain training, say, for example, if a person has an Alzheimer's type of dementia, a lot of these studies have only targeted a single cognitive domain, which is memory. But lately, a lot of these studies on brain training are speaking about the importance of multi-domain cognitive impairment, even in an amnestic kind of MCI. And one study by Zhang and colleagues in 2019 found that computerized training targeted multi-domain cognitive functions, such as attention, logical reasoning, memory, calculation, language, and visual-spatial ability. So indulging in these kind of cognitive skills can decrease cortical atrophy and improve specifically your verbal memory and your visual-spatial functioning. So I'm going to go a little in depth on this study. So basically, the study was carried over 12 weeks, which is 3 months, and the patients underwent training bi-weekly. Each session was about 1 hour. So they had these 6 cognitive domains that they targeted that I just mentioned. So what they did was, in each session, they only targeted 3 of these cognitive domains over a span of 20 minutes. So all activities were divided over 20 minutes. So say, for example, in the first session, they targeted only attention, logical reasoning, and memory. And in the next session, they targeted your language, visual spatial abilities, and calculation. And what they found towards the end of the 3rd month was that there was an increase, there was a decrease in the cortical atrophy and the increase in the gray matter, particularly in the right angular gyrus of the brain, which is very close to the parietal lobe. Although there was no significant effect on the neuropsychological testing over here, we found that there was a clinical significance. There was certainly an increase in the global cognitive scores, and there was a clinical significance in 2 areas. That is your visual spatial memory and the immediate verbal memory. So they saw an improvement in these areas. Now, consistent with this study, there was another randomized controlled trial that was performed to examine the effects of cognitive intervention by 3 types of interventions. That was cognitive domain, type of training, and intervention content. So basically, they wanted to compare multi-domain training versus single domain training. What they found was that there was a significant moderate effect for multi-component or multi-domain training as compared to single domain training. But why are these studies targeting multi-domain training? Let's try to explore that. So there's a theory that targeting these multiple domains and multiple regions of the brain could recruit alternate neural pathways as well as support primary networks to meet the task in mind simultaneously and to activate multiple pathways that are involved in the memory center. Now, memory is just not restricted to the temporal lobes. There are a lot of other factors in memory. There are a lot of other factors that precede your memory, like a lot of your frontal lobe functions, like your working memory, like your frontal executive functions, like organizing information. So whenever you're encoding an information, your frontal lobes need to be intact to be able to organize that information in certain areas of the temporal lobes, right? So you need your executive function to be functioning well. You need your attention to be functioning well. Your processing speed of information should be intact, right? So that's the theory that targeting multiple domains that support memory is very important. And that's the reason there is this, they've proven the efficacy of this sort of intervention. And similarly, there's another systemic review that saw a moderate effect of computerized cognitive training on global cognition, attention, working memory, and learning. And this was done by Hills and colleagues in 2018. right? So now let's talk about some limitations of cognitive training. Now, although there is a lot of evidence for cognitive training to preserve cognition, there are certain limitations to this approach as well. The first limitation is that the long-term effects of cognitive training are unknown, and there are not a lot of studies that have tried to test that. And most of the studies have generally tested cognitive outcomes in the short term. Like the studies I mentioned as well, I think most of the studies were carried out over a period of 12 weeks to 3 months. Secondly, there's not much evidence for the effect of cognitive training on functional outcomes and also psychological functioning. So there's very limited evidence on that. And recently, I went through this data by Cochrane Review by Gates and colleagues in 2019, and they suggested only very mild effect of cognitive training on delaying cognitive decline. But this study suggested that there could be certain confounding factors, and this could be attributed to small trials, small samples, and task inconsistencies. Hence, more research is needed in this area. However, the effectiveness and durability of cognitive training intervention, as proven by the past studies, do show an improvement, even if it is for a limited time and duration. And secondly, because of its affordability and safety, a lot of people could gain access to it, and it could serve as a good home-based rehabilitation between therapy sessions. So now, so far we know that there is evidence for cognitive training, exercising, healthy eating, and socializing in improving overall cognitive functions with patients who have MCI. But recently, a lot of evidence has also been pointing to this multi-component or holistic intervention, in addition to the multi-domain intervention that I already spoke to you about. So this sort of holistic intervention involves, a mix of cognitive training, a mix of physical exercises, some social group activities, all merged into one intervention. And there have been several papers, like you see in this slide, that have kind of supported this claim. Additionally, another study that was done over a long term also saw improvements in cognitive abilities that was maintained up to 2 years. So we are coming towards the end of the presentation. So here at Sir H.N. Reliance Hospital, we run a group intervention for patients with MCI and early stages of dementia. So I'd like to kind of go through them very quickly. Sorry. So here in Sir H.N. Reliance Foundation Hospital, we used to run a memory school where we used to do a mix of cognitive retraining, so targeting several regions of the brain by playing puzzle games, word games. You have quizzes, discussion, reading, storytelling. Then we had some physical activities, so Tai Chi, yoga, mindfulness, meditation. Novel skill learning through art and craft-based activities. And reminiscence therapy, so revisiting memories from the past. And this type of therapy also has, I haven't spoken about it, but this is more relevant for people in the moderate to mild to moderate stages of dementia and can help generate a lot of positive feelings. So that was it. That was me. I hope this talk helped you. And I hope that, I hope that it kind of provided you with some insight on how cognitive training can be beneficial for dealing MCI. And thank you very much. And I'm now going to hand over to Dr. Joy Desai, who's going to be talking about the importance of sleep for the brain. Thank you.
Thank you, Dr. Karishma Jethmalani, for the wonderful presentation.
Thanks.
Okay, now I'll request Dr. Kashyap Dakshini to kindly introduce Joy Desai. Dr. Joy Desai.
Hi, friends. Dr. Joy Desai is a consultant neurologist in the Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Desai did his MBBS and MD in internal medicine at BT Medical College, Ahmedabad, and DND in neurology from Jaslok Hospital. Dr. Desai has more than 15 years of experience in the field of neurology. Dr. Desai is a member of the Indian Academy of Neurology, Neurological Society of India, Indian Epilepsy Association, American Academy of Neurology, and is also registered with the General Medical Council, UK. Dr. Desai has several publications at national and international level to his credit. His main areas of research interest include epilepsy, neurodegenerative diseases, and neurology of systemic diseases. Today, he will speak on sleep for brain health. Over to Dr. Joy Desai.
Thank you, Dr. Kashyap, for that very warm introduction. Thank you, Dr. Arun Shah, for asking me to be here. And this morning, when I was listening to Sir, I was a bit downcast when I didn't find any mention of sleep as a preventive modality of intervention in terms of lifestyle in dementia prevention. But I am assuming that he has left it to be to address this issue. So for us, we are now going to talk, you heard about the various tenets in lifestyle. And if you would really want to distill brain health into what keeps our brains alive, then it can be distilled into the notion that we have to be, it's what we put into our bodies every day. How we eat, how we drink, you heard about that. How we think, you heard about that. How we move, you heard about that. And lastly, how we sleep. So let me try and convince you that sleep is also a medication. So Alan Rechtschaffen, who died a few years ago in 1997, he was one of the foremost sleep researchers in Chicago. And he did a lot of work trying to find the functions of sleep. And he has said that if sleep doesn't serve an absolutely vital function, then it's the biggest mistake that the evolutionary process ever made. The fact that sleep is relevant for and important for bodily health was recognized even 400, 500 years ago. And Shakespeare said that it soothes away all our worries, puts to every day to rest. It relieves the weary laborer and heals hurt minds. And it is the main course in life's feast. And it is the most nourishing. And certainly William Shakespeare had got it right. So what happens when we sleep? Essentially, there are repeating cycles that last 90 to 110 minutes, depending on the individual. Each cycle consists of two phases. The initial phase, called non-REM phase, consisting of stage 1, 2, 3, and 4, of which now 3 and 4 are lumped together, and it's called slow wave sleep or delta wave sleep. And the other phase that follows is the REM phase, which stands for the first letters of the rapid eye movement, because in this phase, the eyes move rapidly, the breathing is stertorous, and the rest of the body is completely atonic. And that's the phase when essentially we are dreaming a lot, though a little bit of dreaming can also occur in non-REM. Now, in these stages, there is an EEG signature. So accomplished neurologists like Dr. Arun Shah or Ishu Goel, when they look at that EEG, can identify which, in a patient who is sleeping, can identify what stage of sleep it is. So it transits from the awake rhythm to a little slowing. And in stage 2, there are very typical signature called sleep spindles and K complexes. And in stage 3 and 4, there are very slow waves called delta waves. And these delta waves are the wave phase is the most restorative. And this is followed by a phase called the REM sleep, where the EEG, paradoxically, it's almost like you are awake and it's a kind of desynchronized rhythm. And the autonomic system is also very active in this phase. So the characteristics of these two phases, very simply, if you want to put it in a nutshell, then the first part, non-REM sleep, characterized by progressive slowing, is associated with decrease in spinal reflexes, a reduction in the heart rate and breathing, a reduced brain temperature and cerebral blood flow, increased hormonal secretion, for example, growth hormone, important for metabolic recalibration, and a very synchronized, slow cortical activity. Whereas in REM sleep, when we are dreaming, spinal reflexes are absent, the eyes move very rapidly behind closed eyelids. the body temperature and cerebral blood flow actually goes up. And if you did a PET scan in REM sleep, the occipital and the association areas of the brain are very hot. And I told you earlier that the EEG rhythm gets desynchronized, almost mimicking the rhythm that we see when we are awake. And this is the phase when we are dreaming. And the key function of REM sleep is to make us emotionally stronger. And we are going to talk about that in time. So in non-REM sleep, there are electrical changes that occur in a hierarchical manner. There are three things that happen. The hippocampus produces a fast activity at 80 to 120 hertz. They are called hippocampal ripples. And this kind of nests with slow wave oscillations at less than 1.5 hertz. And the sleep spindles that occur in a hierarchical fashion in the brain from the front to the back, they occur at 12 to 16 hertz. Now, what's happening is that when these three rhythms come together and function like a symphony orchestra, then sleep memories are getting transferred from the hippocampus to the frontal and parietal lobes for consolidation. And relevant memories get consolidated while irrelevant ones are wiped out. So you can understand that if sleep health is poor, either quality is poor, it is shorter in duration, or it is out of sync with the daylight cycle, then this memory consolidation can be compromised. And of course, one can have problems with memory. So how do we simply understand this? Three rhythms: ripples, slow wave activity or slow wave oscillations, and spindles. They nest together and they create an environment where memory consolidation actually occurs. And this is the diagrammatic representation of the same. The ripple is shown in blue, the delta waves or slowing is shown in brown, and that spindle activity is shown in red. So this is a cartoonized representation of what I showed in the previous slide, just to make it easy to understand. So your hippocampus is like this little pen drive here. Your big brain, the neocortices, the frontal parietal association areas, the occipital cortices, they are like the hard drive. And the three rhythms, they are like the cable that connects the pen drive to the hard drive and transfers information from hippocampus to the cortices. Why is it important? It's important for learning. And it's only when we sleep after we have learned something. You all attended this conference. Make sure that you sleep well tonight, because then you will be able to remember everything that you heard from all our very gifted and accomplished speakers this morning. And this was kind of published in a formal form in 2005. But what happens as we grow older is that in older people, our sleep health seems to change due to a variety of morphological and physiological changes. There is a longer sleep latency. We wake up more often. We spend a greater time awake after sleeping. Sleep is more fragmented. And as we grow older, we spend less time in the deep sleep or slow wave sleep, especially in the early phases of sleep. So this table shows you this change as we grow older. And I direct you to this last column where we compare slow wave sleep in adults and elderly adults. And you can see that the number from about 23% has dropped to about 5% in a geriatric person. And perhaps this was thought to be a contributor to the age-related cognitive impairment that occurs as we sleep, as we grow older and our sleep changes. And it appears that REM sleep also, as we grow older, in this diagram, you can see that as we grow older from youth to death, the REM sleep quantum also becomes smaller. And I explained to you that REM sleep is important for emotional strengthening. And it is not surprising that you find in the clinics that older people, the older they age, if they have aged without a great investment in their lifestyle, tend to be a little more anxious than younger people. And this is not a conjecture. This has been studied and it's been confirmed. So this is a very wonderful article by Matthew Walker. Old brains become uncoupled in sleep. Slow wave spindle synchrony, brain atrophy, and forgetting. Very lovely article which says that as we grow older, because of our prefrontal cortex being atrophied, this prefrontal cortex is the main generating area of the brain that is responsible for the nesting of the three rhythms, the ripples, the slow waves, and the spindles. And this atrophy leads to forgetting in age. So this is the first author was Bryce Mender, who's a colleague who works, he's a psychologist. He works with Matthew Walker. And you can see here that the red bar is young adults and the blue bar is older adults. So as we grow older, the prefrontal cortices shown here diagrammatically tend to become atrophied. And if this happens, it results in our memories changing. It also changes how the amygdala will talk to the prefrontal cortex in sleep. And the function of that, of REM sleep, is to take away the emotional context of traumatizing memories. So if you have traumatic experiences in your day-to-day living, then you have a memory and you have the emotion. The longer you sleep well every day, the emotion part, which can be traumatizing, gradually disappears, as shown in this diagram. And the memory remains, but without the emotional context. So therefore, sleep enhances emotional strength. That's the thing to remember. Which phase of sleep? It is the REM sleep that helps us emotionally stronger. And this has been published in different formats and discussions that REM sleep depotentiates amygdala activity to previous traumatizing experiences. Self-reported sleep correlates also show the same, that if you're sleeping less, then it correlates with a higher perceived change in your emotional functioning, and sleep deprivation affects fearful memory consolidation, and it makes people more stressed, more emotionally vulnerable. So you and I should be asking the question that, hey, if my prefrontal cortex is likely to shrink as I grow older, what can I do and what should I not do to not allow this to happen in a very dramatic fashion? So brain injury, aging, alcohol binging, depression that Dr. Asutosh so elegantly talked about, and sedentariness, which Ashish referred to, can all result in a greater prefrontal cortex atrophy. What can prevent it? Exercise, mindfulness, yoga, enthusiasm, and passion. And you heard Karishma speak about learning novel skills with enthusiasm and passion. And lastly, social connectivity and social wealth, being well connected in a social network. All of these are akin to mindfulness. It is there, it's akin to exercise psychologically, and it helps the prefrontal cortex, which I've shown you here very nicely in this color diagram, in violet, in purple, in yellow, and green. The prefrontal cortex preservation depends on how we tend to balance these two things every day in our lives as we grow older. I told you that non-REM sleep is responsible for memory consolidation, and this occurs in that phasic manner. We now know that REM sleep is responsible for emotional salience, and its deprivation can make us anxious and lead to cyclothymic mood dysfunction. And the final important function of sleep is waste clearance via a system called the glymphatic system, which was discovered in 2013. So the thing to understand is that as we sleep every day, sleep is necessary because the brain is sculpting our synapses in sleep. Sleep is sculpting the brain and its synapses and creating good memories, important memories from that whole burden of lots of memories that we accumulate every day, and keeping those memories that are relevant intact. And so what are the key functions of sleep? Memory consolidation, emotional salience, protective behavioral adaptation, biochemical waste removal via the glymphatics. I'll talk about that in the next 3 slides. It removes beta amyloid and tau, energy conservation, body growth restorative physiology, regulation of immune function by making our natural killer cells better, and energy homeostasis and regulation of weight. And these are vital for health preservation. What about autonomic calibration? We know that sleep loss and disruption results in hypertension. And we also know that stimulation of the amygdala and cingulate gyrus in the insula and prefrontal cortices, all of them can change blood pressure. So what Matthew Walker's group did with Adam Krause was to study 66 healthy adults who were sleep deprived, and then they were sleep repleted. And then their heart rates and blood pressures were measured, and their resting state functional imaging of the brain was done. So when they were rested, their blood pressures, both systolic and diastolic, was lower. And that's shown in the lower bar charts on the left. And when they were sleep deprived, their BPs went up. And that is shown in the red bar chart on the right. And the similar thing happens with heart rate. The heart rate in the sleep repleted ones is regulated versus the sleep depleted ones, it changes. So which means that our autonomic system has a neural network in the brain with an increased connectivity in certain areas, which I've shown you here on the left-hand side in red, prefrontal cortex, the anterior cingulate, insula and amygdala, and a decreased connectivity between regionally between the prefrontal cortices in sleep at night. So what it means is that sleep loss can change this connectivity, and when this connectivity changes, it increases systolic blood pressure. And when the connectivity between the amygdala and prefrontal cortex changes because of sleep loss, it increases the diastolic blood pressure. For those of you who are interested, there is a wonderful paper from the Mayo Clinic written by Meghna Mansukani. It's called the Arthur C. Corcoran Memorial Lecture, where she talks about insufficient sleep and sleep apnea as an important and perhaps the only major contributor to hypertension. So what we call essential hypertension has been shown in the CARDIA study, the coronary artery risk development in young adult study, that even 1 hour of decrease in sleep length yields a 37% increased risk of elevated blood pressure. So for those of you, you should know that our blood pressures are regulated when we sleep. Not only that, it helps us look younger. So this is a study which correlates insomnia and telomere length. We know that our longevity is dependent on our telomeres. You must have read the book, The Telomere Effect, which talks about the importance of telomeres in biological longevity for all species, including humans. And we now know that when we are sleeping, our brain is actually preventing us from dying by maintaining our telomeres. It also improves our natural killer cells. I mentioned that. It also helps us to helps us to perceive pain with less severity. And when we are sleep deprived, our pain perception goes up. And that is why patients with migraine, when they don't sleep well, have very bad headaches. And it makes us emotionally vulnerable. And that's been published too. And this is a very elegant paper called Haunted by the Past. Old emotions remain salient in insomnia. So if you don't sleep well, then old nasty memories don't go away from your brain and you relive it for a long time. So for clinicians, it's important to understand if you're sleep deprived and you are vaccinated against COVID, your vaccinal response, antibody response is not as good. Therefore, sleep enhances our immunological environment, not only via natural killer cells, but it also helps us to regulate our B cell lineage and prevents autoimmune disease. And I told you about the glymphatics. This was discovered in 2013 by Mike Nedegard. What is it? Very simply, it is a sleep-activated brain biological cleaner. And in a nutshell, it's a flow of CSF from the artery to the vein exclusively in sleep, which abates when we wake up. Supine and lateral position is great, whereas prone sleeping reduces its efficiency by 40%. Voluntary exercise and low-dose alcohol can actually enhance it, whereas head injury, diabetes, strokes, lacunar infarct, sleep apnea, all of them impair the glymphatic efficiency. And if the glymphatic system is poor, then it cannot excrete beta amyloid and tau in normal asymptomatic people. And this is a diagrammatic representation. And you can see that the flow of CSF from the artery to the vein, from red to blue, across in a unidirectional manner is regulated by this superb brain cell called the astrocyte. It is truly a star of brain biology. And it has a gating molecule called aquaporin 4, which is responsible for the directionality of the CSF. So the astrocyte is a star. It's an important cell that does a lot of work when we are sleeping, and it helps in clearing waste when we sleep. It requires the polarization of the aquaporin 4 to the foot process of these cells. And how can we help our astrocytes to be more polarized? By maintaining a good diet rich in vegetables and fish oils, by exercising, including Tai Chi, low dose alcohol, meditation, all of them, and intermittent fasting, for example, all of them enhance polarization of aquaporin 4. And this helps to clear amyloid, especially when sleep hygiene is good. And this can be disrupted, of course, when you have a sleep disorder like insomnia, sleep apnea, and fragmentation. And now there are lots of studies. This is the Severin Sabia study from Europe, which clearly showed that if you have short sleep duration at age 50, 60, and 70 compared to normal sleep duration, there is a 30% increased risk of dementia independent of sociodemographics, behavior, cardiometabolic, and mental health factors. So sleep is an important investment for dementia prevention. There's a similar study from Los Angeles. This was published 3 years ago, where you heard Dr. Ashutosh Shah tell us that if you're depressed, then there is a change in the microglia in the brain. They become more phagocytic, and this is also regulated by our sleep. And sleep fragmentation increases the expression of aged microglia and activated microglia, increasing the risk of dementia. So what does this imply? As we grow older, the aging brain undergoes structural atrophy in the prefrontal cortex and a secondary electrical synchrony failure. This leads to greater sleep fragmentation, shorter and inefficient deep sleep. So memory consolidation becomes poor, upregulation of activated microglia and poor glymphatic function results in a greater amyloid and tau burden in the brain. And Dr. Arun Shah very elegantly showed you pictures that we can image, and this has been shown to occur in patients with sleep apnea. So very simply, poor sleep with age results in accelerated cognitive decline. So we must invest in exercise, habit discipline, and meditation, because all of these are going to aid sleep hygiene optimization, sleep depth optimization, and sleep quality. So my take-home message to all of you is that sleep is a biological medication. It is not a deaffrantation from wakefulness. It has evolved in nature as a measure to recalibrate all tenets of bodily health every single day. It regulates our blood pressure, blood sugar, our fat storage, our mental health, and memory. Benefits of sleep are best accrued when the duration is good, the quality is good, and the timing is good. The timing has to be optimum. We have to sleep between 10:30 and 6:30. That is the time that nature has ordained us to sleep in sync with the daylight cycle. If we don't sleep in sync with the daylight cycle, it's called asynchrony, and asynchrony is not as beneficial. Just like diet, just like meditation, just like exercise, sleep must be invested in daily to maintain somatic and brain health. And sleep harmony in middle life protects against the risk of developing dementia. I showed you the publications. The suspicion was there. Now it's been proven in very well documented analytical studies. So if you look at the things that we discussed for brain health, how we think, how we sleep, how we socially interact, how we exercise, and what we put in our food and nutrition, all that is important. And I want to emphasize today that amongst all of these, sleep is as important as all the other tenets. And if we can take this home today, then we have made sure that we will live better and we can help our brains stay healthier. Thank you for listening to me. And thank you, Dr. Arun Shah and the IMA for asking me to participate in today's meeting.
Thank you, Dr. Joy Desai, for the wonderful lecture on the sleep, the importance of sleep in daily life. Now we go on to the panel discussion, and I'll hand over the host to Jitesh Mehta. He will host the panel discussion. Dr. Jitesh Mehta.
Yeah. Friends, we have Dr. Jitesh Mehta with us. He is our immediate past president, and Dr. Arun Shah and all the panelists will be knowing because he was there who conducted last year's Alzheimer's Day program. Dr. Jitesh, take over the charge of the panel discussion.
Yeah, thank you, Dr. Anil. And a very good afternoon to all of you, Dr. Arun Bhai. I must congratulate to your whole team. A wonderful set of lectures,
Yeah.
listening to great knowledge, which is being dished out to us. And I'm sure many of us have learned a lot from today's webinar. So let us end this with a panel discussion. I shall invite the panelists online. Dr. Karishma Jetmalani, Dr. Joy Desai, of course, you're there, Dr. Arun Shah, and Dr. Ashutosh Shah. So yeah, so I start with the first question, and I shall ask Dr. Arun Bhai to answer this question. Can you update us on the advances in the treatment of Alzheimer's disease?
Thank you, Dr. Jitesh Bhai, for asking this question. I think this time I totally missed the treatment part in my basic talks on dementia, basically because I thought the 1 year no advances occurred. So at the moment, pharmacotherapy for Alzheimer's dementia remains in the same stage that it was in last 5 to 10 years, which consists of giving cholinesterase inhibitors in people with mild to moderate dementia, which are 3 compounds available are, of course, the rivastigmine, galantamine, and donepezil, which we use it. 50% of patients benefit, and the benefit continues for the first few years, and later on, of course, they don't benefit much. And the other compound, of course, is mementamine, which works a different mechanism, the NMDA receptors, and that is also used from mild to moderate to advanced dementia. Now, as we know, these are all symptomatic treatment. It works by altering the chemical balance in the brain and improves the cognitive functions, and that's how it will reduce the behavioral problem. Only additional therapy, which we thought was very promising last year, was use of edicumab, which is a monoclonal antibodies, which is supposed to reduce, it is against amyloid and reduce the amyloid content in the brain. Now that is approved by US FDA, and we thought a promising drug, but there was a lot of controversy about it, and it has a lot of side effects. And of course, it is used only for very early cases. That means at the stage of MCI or people who have no dementia, but who have large amount of amyloid in the brain. Over the last 1 year, the experience has not been that great, and I'm probably were disappointed that we'll not have that drug. But of course, there are 2-3 drugs coming on the same line. Probably they may have the same fate, because what was observed in that your imaging improved, the amyloid did reduce in the brain, but there was no associated improvement in clinical status or cognition. So there is a lot of skepticism about this amyloid theory itself has grown now because of this failure when using this drug in the absence of clinical response. And of course, we use many other drugs basically to control behavior. In fact, we prefer that drugs are not to be used, but sometimes we have to use it. I think since we are on this topic, I would request Dr. Joy Desai to talk about if we have sleep disorders in people with Alzheimer's dementia, which drugs he would recommend.
Yeah, Dr. Joy.
Right, that's a very, very important question. So there are different ways in which sleep disorders can get and infringe on brain health. I showed you its ramifications. Now, if you broadly see people who either are not sleeping because their sleep quantity is short, they are not able to maintain sleep, or they have a sleep disorder which is infringing on sleep health and recurrently keeping them awake. So the ones who can't sleep due to insomnia need therapy. Ideally, insomnia should be treated early with cognitive behavioral therapies, with the right sleep hygiene measures. And if those fail, then one may have to use a somnolent. We have all been using benzodiazepines, but you heard Dr. Ashutosh clearly tell us that they are not the best drug. Now we have a new category of drugs. They are called the dual orexin receptor antagonists. They modulate how the orexin is responsible for awakening. It can regulate that. There is a drug called lemborexant. It's available in India now. The trade name is Dayvigo, and one can use that judiciously along with melatonin to try and help them sleep better. If somebody has sleep apnea and they are waking up very often because they are hypoxic in their sleep, one can do a sleep study, identify sleep apnea, and if you use CPAP and correct sleep apnea, then they sleep better and their sleep quality improves. If they have periodic leg movement disorder, for example, and they are waking up because they are making leg movements very often, then you have two avenues in which you can treat them. You can do their iron studies and replace iron, because we think that is one pathogenic cascade that results in periodic leg movements. And one can use alpha-2 delta agonist therapy, like either pregabalin or gabapentin, which is usually chosen. And one can also use a dopamine agonist like pramipexole or ropinirole to treat the periodic leg movements and help their sleep better. I think overall, there is also a very important need to sensitize and create advocacy for sleep, so that in middle life, my age, people who are not in the geriatric phase yet but are getting there, they have to invest in sleep in a correct manner by disciplining their sleep habits, good sleep hygiene, which means exercise in the morning, avoid coffee after 3 p.m. You can have your coffee 2 times if you like, but before 3 p.m., because coffee is an antagonist of adenosine and it prevents sleep. It's got a long half-life. If you want to drink something at night, you can have chamomile tea or you can have lavender tea, which is sleep promoting. And exercise should be done in the morning. So if you invest in habits in the correct time, reduce screen time by about 9:30 or so, create a nice ambience in the bedroom, correct temperature and lighting, then you can sleep better. If your sleep hygiene is good, it's brain protective. So I think we can do all of these things to our patients and help them preserve their brain health, as we discussed in the session in the morning.
So, since you mentioned about melatonin, I just wanted to ask you, how long does melatonin take to initiate the action?
It takes about 45 minutes. So ideally, it should be consumed 45 minutes before the intended time to sleeping. I normally recommend 9:30 to 9:45 because I want my patients to sleep by 10:30. There's only a small caveat. A lot of patients ask, will melatonin make me groggy? 80-90% of the times it does not make you groggy. But there is a CYP 450 system polymorphism in a small number of people. About 3% of people have this polymorphism. They are not able to metabolize melatonin and they can have morning grogginess. But otherwise, by about 7 o'clock, most of the melatonin is metabolized to 6-sulfa-methoxy melatonin, and it's already excreted in the urine. So it's not there in the system.
Nowadays, you have got combinations of pregabalin with nortriptyline. So what is the action of nortriptyline in that with pregabalin? And we tend to, as family physicians, this is the thing which
I think you.
Yeah.
You want me to take that, Dr. Shah?
Yeah, I think whenever I come across a prescription where somebody has combined it, I remove it.
Yeah.
I don't believe in combining drugs.
So there are a lot of
like
people
to use it in.
So a lot of people who are like us who are purists. So I'll tell you how it has evolved. It has evolved because of neuropathic pain in diabetics. The commonest big community is diabetic neuropathic pain. And in diabetic neuropathic pain, you can have pain as an infringement at night. So companies decided that when doctors were using either duloxetine or nortriptyline in conjunction with pregabalin as a combo, which works for neuropathic pain, why not put it together? But the downside is that if your patient doesn't tolerate the drug, you don't know which one he is not tolerating. And good physicians, Dr. Shah and others, myself, we like to keep our drugs separate. And you try one drug at a time and then add a second one if the first drug has failed.
Thank you. I shall ask a question to Dr. Ashutosh Shah. Wonderful talk you have given. How should we address the issue of behavioral problems in patients with Alzheimer's dementia?
So first of all, thank you for having me here. Dr. Jitesh, it was a pleasure remembering seeing you last year. I'm still not having any cognitive impairment. But this term behavioral and psychological symptoms is an imperfect term. So first of all, for lack of any alternatives, we are still stuck with it and we use the acronym BPSD. And it actually covers a host of problems: mood disorders, thought disorders, perceptual disorders, and a lot of things come under this umbrella term, even sleep disturbances, agitation. So it's like a khichdi of everything. And actually BPSD happens in every patient of dementia at different stages of the disorder. And whenever it happens, it actually causes a lot of distress, not only to the individual, to the caregivers. It becomes costly. One of the reasons for hospitalization, increases the morbidity as well as the mortality. So a lot of things actually go on when we are seeing this particular BPSD, though the hallmark is actually cognitive impairments. And the approach should not be knee-jerk. So for example, as family physicians, if somebody gets a phone call saying that there is shortness of breath, you do not assume that this is pneumonia and straight away jump to giving antibiotics. So there has to be a systematic approach, first of all, to describe. So the DICE approach, DICE. So describe, often including even the nursing staff, it's surprising. They put labels, and that's something which is, what is agitation for one is not agitation as we understand it. So we have to actually ask them, please give it in categorical details without putting any labels to what you are seeing. So first of all, inferred. So often we come to know that there was a situation, the person could not manage it, got agitated, and then we need to investigate what really happened. So they were having a bath, the temperature was too hot, and they got angry. So obviously, the individual did not have the cognitive ability to communicate the temperature of the water is too high and showed an annoyance. So here, a simple thing would be to test the water, just like, when somebody is bathing a newborn and the newborn can't answer, he's going to shout and cry. Exactly same thing happens in a dementing individual. So second step is to investigate. Third step is to create a plan. So after all this, we have to figure out what are the factors and look at three things: patient factors, often hunger, infection, pain, constipation. These are the underlying things which are happening in the patient presenting with behavioral problems. Figure those out. The patient may not be in a cognitively intact state to actually communicate what is happening. So one may need to closely observe. Second thing is the relative factors. So sometimes unrealistic expectations. People coming and telling, I'm not talking of dementia, their 80-year-old father is not sleeping 8 hours a night. No, it is known with aging that the sleep structure changes, it is fragmented. So we have to actually put the perspective and not give in to the pressure to just simply prescribe a sleeping pill to this particular patient. The other relative factor is they may be depressed, and in depression, they can have misinterpretations and they may be having less control over their emotions. So figure out caregiver burnout, distress, depression. And third, of course, negative communication. They may have hostility because you see they are losing income, they may be losing their personal lifetime. So all this needs to be figured out. And the third thing is the environmental variable. Often the individuals are not getting adequate exposure to sunlight, or they're getting overstimulated. So one of the things, if I can add on to the sleep problems which Dr. Joy and Dr. Arun Shah sir were discussing, at night, if the lights are on, they are not going to get sleep. And bright lights may not be in the room, but coming from outside. So a simple thing would be just night curtains could be helpful. So all this, once we have understood, we have created a plan, then we prescribe, if needed, a particular medication. So there is this fear that we should not use antipsychotics. I don't know where this is coming from, because if used judiciously after doing everything, there is the evidence, of course, modest evidence, that antipsychotics are the only ones which are helping in treating this kind of behavioral disturbances. But they are not like a panacea solution. They have to be given case by case. And of course, what happened was, in 2005 and 2008, US FDA gave a black box warning to the atypical and the typical antipsychotics. So people, at least in US and other parts of the world, stopped using antipsychotics. They started using more of mood stabilizers, which themselves also have a lot of problem. And I heard you asking about pregabalin, nortriptyline. One of the reasons why this shift had occurred was because of this warning. So far, risperidone is the one which, used judiciously, has good action in controlling the behaviors. So in controlling BPSD, all the steps have to be first describe, then investigate, create a plan, and then evaluate. So even if we are prescribing risperidone, it's not lifelong, indefinite period. Periodic intervals, we have to investigate, are there any side effects coming up? Because you see what happens is, all antipsychotics, they interfere with the musculature involved in deglutition. So there's a real risk of a inhalation or swallowing of the saliva, and the individual landing up with a pneumonia and then subsequent death. So one has to be pretty much careful. Start low, go slow. That is the mantra over here. And then if the person is behaviorally controlled, we don't continue. We slowly try to remove it, see how is he or she is maintaining. And then if needed, use it again So this is what I would kind of advocate.
Thank you very much. That was a very elaborate answer. I shall now address Dr. Karishma. What kinds of psychological testings might be done in dementia evaluation?
Right. So basically, we do a very comprehensive psychological and neuropsychological testing when we suspect that a person is having certain problems with cognition. So we do one generic cognitive assessment to begin with, which has around 9 cognitive domains. So it measures your orientation to time, place, and people, your attention, your registration to information, essentially your working memory, then your recall, your short-term and delayed recall both, your language functions, your visuospatial functions, your verbal fluency. So the generic cognitive test, generally I use the Addenbrook's cognitive examination since we have the normative data for the Indian population. Then we do a more domain-specific assessment. So if we suspect that a person is having memory difficulties, so we'll add more memory-based domain-specific assessment that is a little bit more higher level than a global cognitive assessment. And then we do a mood assessment to understand any presence of anxiety or depression, a neuropsychiatric assessment to understand behavioral problems. So based on this neuropsychological profile, we identify a person's strengths and weaknesses, and we see how can we use their strengths, their cognitive and whatever general strengths to compensate, to help them compensate for the weaker areas. So that's what the assessment consists of.
Okay. Thank you. Dr. Joy, what lifestyle habits are responsible for sleep disruption and suboptimal sleep benefits?
Yeah, it's a very, very relevant question that you're asking. You know, when we as physicians and internists and neurologists, we are all taught about identifying patterns and then figuring out whether this pattern is not compatible with good health. The question we ought to be asking is that why did this pattern actually develop? And what happens is that our sleep cycling is a very fragile biology that is wired and based on feedback loops. So what you are doing to it every day, it is taking as a signal. So if one day Joy Desai sleeps at 10:30, the next day he decides to watch Netflix and sleeps at 1 o'clock. The third day he goes to a party and he comes back at 3 a.m. after drinking lots of alcohol, right? And then the fourth day he tries to go back to bed at 9:30 because he has a morning flight to catch. His brain is confused कि boss ये कब सोने वाला है? ये 10:30 को सोएगा, 9 बजे सोएगा, 1 बजे सोएगा, 3 बजे सोएगा, and the biofeedback of your timing is completely disrupted. So regularity is the key of keeping our biorhythms intact, and that regularity is based on discipline. That is why I said we need to invest in it by our understanding. So lifestyle irregularities, you may get away with it when you are young because you have greater brain reserve. When you are older, the system is fragile, its brain reserve is lower, and it will fall apart. So that's one. Second, when a lot of people now have adopted this Americanism, so they have a very busy day, then they go to the gym at 8:30 at 9 and they do weights. They come home, have a hefty meal at 10:30. Now, actually, your physiology, if you look at all the nutritional physiology, your brain and body is best wired to consume your last meal by 8 p.m. What the Jains say is absolutely correct. Because physiologically, if you consume a meal at 10:30 and 11, you'd be surprised, it also changes and worsens your sleep apnea. Late meals can worsen your sleep apnea. It can alter the sensitivity of a respiratory center. Studies have been done. So discipline again in the right timing, understanding that if we have a meal early and we have 2-3 hours of gentle, refreshing pastime, maybe reading a book or listening to music or doing something non-stressful for a couple of hours and then going to bed is far more amenable to the metabolic cycle and the sleep cycle remaining stable. So exercise in the morning, not in the evening if possible. Yes, you can walk late evening, but don't do weightlifting at 7:30, 8 and 9 o'clock. Try to get your meals done earlier. If you do like your alcohol, as you heard Dr. Asutosh say that it's bad for the brain, If you do like your alcohol, drink it earlier. Don't drink late into the night, because any alcohol consumption doesn't help your sleep. Alcohol consumption prior to sleep actually has been shown to make your sleep fragmented, and deep slow wave sleep does not occur. So there are so many things that we don't think about that we are doing to our bodies unknowingly, because nobody told us that this could have a far-reaching fallout if it's repeated on a regular basis. So hydration, that's why I said it's the 5 pillars: how you think, how you drink, how you eat, how you move, and how you sleep. These are the 5 pillars for health.
Thank you. I hope all the family physicians are listening and listening about the fact about having early meals, in the evening. So our practice keeps on going on till late night after sunset, 9,
And
10.
we doctors need to heal. So we doctors need to introspect, and we doctors need to work on our science. There's no point knowing science if you can't work on it.
Very good, yes. Dr. Karishma, what roles do families and other caregivers play in treatment?
Right. Families and caregivers play a very, very important role in with a person who's suffering from dementia. And I would like to talk a little bit about how family members could help a person who's suffering from dementia in particular. So in the early stages, when a person may have mild problems with their memory, with their logical reasoning, and just with some complex activities, in those stages, they might not require so much help from the caretakers and the family members. But later on, as the disease progresses, people may have problems with their basic activities of daily living, such as bathing, such as dressing, not keeping up with appointments and events. So that's when family members come in handy. So it's very important for the family members to see a person in a non-judgmental light. That's very important. Like a lot of times I've seen family members complain that their loved ones are, pretending like they have memory problems or pretending that they're not able to do certain things, right? So I see them talk and deal with them in this very harsh way. So I think first it's very important for them to educate themselves as to what is the progression of the condition. What are the neurophysiological factors that are involved, which areas could be affected. So that psychoeducation part is very important, to educate themselves about the possible consequences. Then another approach is they can help their loved ones to kind of get on with their activities of daily living and not expect the person suffering from dementia, to kind of figure it out on their own. Now, again, I have a lot of the caregivers saying that this patient doesn't do activity, he sits all day, he can't play a Sudoku, he can't take his iPad and sort of, start playing word search. But little do they realize that that the person's planning centers have been compromised. And that entire act of initiation may become very difficult later on because of this problem within their planning and organization centers. So it's very essential for the family members to guide every patient through every process, right? Sort of make a timetable for them, sort of, plan things for them, set reminders, set alarm clocks for them, right? You can help the person write a to-do list. They can help them train in more complex areas like, managing their finances, organizing, planning something, while making sure that the person, while giving very minor prompts rather than kind of doing all the hand holding for them, so that, they're still able to, so the patient is able to feel that they're still able to do something, and that they have this sort of choice or this sort of agency. That's very important. And thirdly, it's very important that the caregivers take care of their own mental health as well, because if you're not able to take care of yourself, you may never be able to provide that level of care to the patients. So it's very important that the caregivers also visit counselors and look after their mental health. And fourthly, in India, we have this advantage of joint family systems. And it's very important for not just one person to take over the entire role, but to segregate the tasks to different people. So say, for example, the patient's, son can kind of spend 1 hour every day with the patient, or the daughter can, dedicate a couple of hours every day. So this is, so we have the advantage of joint systems in the Indian setup. So we should definitely make most of it. And again, just to reiterate, caregivers' mental health matters a lot. like they say that you always have to put the oxygen mask on yourself first before helping other people. So if you're not able to take care of yourself, you'll never be able to take care of your loved ones.
Yeah, and so the family members do have to give a lot of extra time. They have to plan for these patients who
Yes.
are there. And
Yes.
when they divide the role, I think it becomes more easy.
Dividing the role is very important.
Very
And
important.
that's not the advantage that we have in India.
Yeah.
Yeah.
Arun bhai, a couple of questions to you. Can you give us any particulars about any antihypertensive drug which is better for prevention of dementia? A patient with a hypertensive.
I think we discussed this at the end of my talk, because I
Yeah.
think there are 3-4 trials, antihypertensive trials, and one of them is, of course, the systolic hypertension for Euro trial, CysEuro, which used the calcium antagonist along with enalapril and diuretic. And that trial is the only trial which showed that there was a benefit in the presence of dementia. So they followed up people after the trial for almost 4 years, and they showed that there was almost 50% reduction in the rate of dementia, which was not only the vascular dementia, but also Alzheimer's. So that means calcium antagonists and ARBs or ACE inhibitors have some role, protective role. Now, there are other SCOPE trial and SCG trial which use other drugs. It was not, there was no benefit. And of course, the PROGRESS trial, which again used indapamine and ACE inhibitor, again showed that there was a positive response. So there is maybe some class effect, but of course, there are no prospective studies to differentiate between other drugs and these. But we can always say that use of ARBs, ACE inhibitors, and calcium antagonists, along with the diuretic, might be superior in the control of BP in people who are prone to develop dementia. I mean, this is just a statement, not completely proven, but there are some indications that some trend is there.
Is there any relationship between pregnancy-related hypertension and future dementia?
Yes, so this is very important information which has just come up 2 weeks ago. That epidemiological studies have been done, and what they found that, of course, pregnancy is a young age phenomena and dementia is elderly phenomena. But even in that study, what they found that if those women who had pregnancy-related hypertension, when they followed up over a period of say 20 years or 15 years, the risk of vascular dementia was high by almost 1.6 times, and also Alzheimer's dementia was high by almost 1.5 times. So that means pregnancy-related hypertension again now is considered as a risk factor for dementia. Now, whether this information should be used for prevention by taking proper antenatal care and proper monitoring is what is advocated. So that's just new information which epidemiology study was just presented in August in the Alzheimer's Association meeting abroad. So I think this is something which we need to still digest it and follow it up.
Can I come in here a minute?
Yeah.
It's very important for all of us to understand that one of the physiologic antihypertensives is sleep. There is so much data now that shows that sleep disorders are a driver for hypertension.
Right.
I have a young colleague, my age, no longer young now, of course, we are all in middle life, who was on 4 antihypertensive medications being treated by another of my colleagues. And she called up and told me that, look, Joy, 4 drugs are still not controlling his blood pressure. I think we should get his sleep study done because I believe he has a sleep disorder. We did his sleep study. His sleep apnea index was 42. He has been put on CPAP for the last 6 months. And from 4 drugs, he's come down to 1 and his blood pressure is controlled. So this is just an example, but I tried to show you in my presentation that we have a lot of science information which tells us how sleep is a regulator of the autonomic system, including our heart rates and blood pressure. So we must give antihypertensives, as Sir pointed out, based on our trial data and our understanding of what it does. But we must also ask patients to invest in their lifestyle. Right. Even 1 night of sleep deprivation in the Krauss study, 1 night can push up your systolic blood pressure by 10 to 15 millimeters the next day.
So sometimes we have some nights where we don't get sleep, and then some night you oversleep, like, okay.
Yes.
Does that compensate, make up?
Not really. At least we know for sure that there's this phenomenon. I don't know whether everybody knows in this forum, but there is this phenomenon which is now called the civilization or the urban lifestyle. So what happens is people sleep late by 12 and 1. They wake up early at 7 because they have to go to work on Monday to Friday. And then they think that on Saturday, Sunday, now it's my weekend time. I will watch Netflix till 1 o'clock, but I will wake up at 11 and 12 in the afternoon. So this phenomenon is now got an official label. It's called social jet lag. And this phenomenon was called social jet lag by Till Ronenberg, who's a Danish researcher. And social jet lag has the same fallout of ill health as sleep deprivation. So this timing of sleep is equally important. So circadian synchrony is not understood, it's not emphasized by us. When we doctors are not convinced, we not tell our patients. I personally feel that all of us should take interest in this, and we must, as family doctors, tell our patients why it's important for them to adopt a good lifestyle investment on a regular basis. Of course, we have medications, but we also have to look after our physiologies.
Very true. Thank you very much. I think we shall end this panel discussion. Anyone who wants to add some important information, you can please add on. Any of the panelists? Wonderful insight by all of you.
I just want to tell Joy that was intentionally I had not addressed the sleep because I thought you were going to. I had given you the whole topic.
I thought as much. I thought as much. I thought as much.
Okay.
And
so, as family physicians, we know about pregnancy-related hypertension and diabetes, which can come in later life. But this dementia is a different angle now.
Right.
I mean, it's amazing what we are learning, how our bodies are changing every day. And,
yes. Very true. I think I shall hand over to Dr. Howard and Dr. Kajal.
Yeah. Thank you very much, Jitesh, and all the panelists. It was a wonderful discussion on a very important topic nowadays. We are seeing so many of dementia and Alzheimer's. We do not have Dr. Vajay is there. Vajay? Okay. Then I request Dr. Jitesh to do one more act of work for me to propose a vote of thanks.
Okay, friends. I would like to thank our speakers of today's CME, Dr. Arun Shah, Dr. Ashish Contractor, Dr. Ishu Goyal. Wonderful case presentations, very, very important to depict her points home, Dr. Ashutosh Shah, Dr. Karishma Jethmalani, and Dr. Joy Desai. All of you have been wonderful speakers. I thank our knowledge partners for the day, Dr. H.N. Reliance Hospital. I thank Dr. Kajal Ahuja, Assistant Director, IMA CGP Sub-Faculty, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Sachin Patarkar for being the MMC observer for today's session. He's a part of our committee. Last but not the least, I thank all of you delegates for participating in this webinar in large numbers and making this a grand success. Thank you very much. Thank you one and all.
Thank you. Thank you very much.
Thank you for having me here, and thank you, Dr. Arun. Thank you.
Right. Thank you. Bye-bye.
Thank you.
Thank you very much, Arun Shah, sir. Thank you.
Yeah. Thank you. Thank you very much.
Depend. Depend. Depend G.